So much in like how women are not tiny men, kids are not tiny adults. There are significant differences between how we treat pediatrics or how we approach pediatrics versus how we approach adult patients. I want to say that the most common difference that we talk about when it comes to the differences in the anatomy of adults versus pediatrics is we really focus a lot on the airway and how the airway is differently shaped, which is kind of why we don't use a cuffed tube, and it's why the kids are at a higher risk of choking because of just the way that their airway is shaped. It's very funneled shape. But there's other concerns as well in terms of how well their liver is able to function, how well their kidneys are able to function, which is why we don't really push a lot of those heavy medications on them as we do with adults. Their little tiny bodies are not really good at handling that, so we try not to overdo it. Different, and we talked about this in our lifespan chapter, but the differences between newborns. Andrew, mute, please. The differences between newborns versus infants, we have different age ranges, right? So these are your age ranges here. And when we talk about neonates are like a few days old. So we talked about those last week. Just a quick little review on that. So, various issues that newborns may or may not have a lot of the time, respiratory problems, right? Something as simple as a stuffy nose can impact a newborn because they are obligatory nose breathers. Jaundice is very common, especially in premature and Asian descent children. They get to go spend some time under the UV light like they're tanning. Vomiting due to various, twisties and turvies of the intestines that are not really what they're supposed to be. Sepsis and meningitis, right, are also two considerable complications because they don't have exactly the world's most robust immune system. They can fight off a lot of things because of if they are breastfeeding and like the first couple days when they still have mom's immune system kind of giving them a boost. But as they start to get a little bit closer to that 1 month and older age is when they can start picking up a lot of bacteria and infections. Infants, super cute most of the time. Every once in a while you get like a really ugly baby and you're like, oh my goodness, what happened? But most of the time super cute. This is an evolutionary trait because no one wants to not take care of a super cute baby. A lot of the times the person who's going to tell you that something's wrong with the baby is mom or dad, right? Or whoever the caretaker is spends the most time with the baby. Because they are the ones who know that child the best. They're going to know, like, oh no, he's not, colicky. Like this, he's always a really well-dispositioned baby. He goes down for a nap really easy, right? Or no, this baby all of a sudden, like, he's usually kind of grumpy and now he's really lethargic. So there's a number of, different perceptions of the caretaker that you really need to take into consideration. Other issues that usually you see in babies are usually respiratory. We talked about SIDS is still a concern up till about 2 years or so. SIDS can still happen. It's a sudden infant death syndrome. They call it something else now that I'm blanking on right now, but I believe it shows up a little bit later. Older infants, right? Bronchiolitis, croup, epiglottitis. These are all concerns. Physical injury is an issue, right? Especially when they start getting to that standing with support and walking age, when they start trying to move around the house and maybe they lose their balance because they still have a big old pumpkin head. Things that I always appreciate is when you have a mom or dad who has a 1-month-old baby who they say rolled off the bed. To me, that's super suspicious, right? You see, 4 to 5 months is really where babies are starting to be able to roll over. So anyone any baby younger than about 3 months who is supposedly rolled off the bed, you should have a high index of suspicion that something else is going on. Everyone's like, oh, infants are hard, babies are hard. Toddlers are supposed to be actually harder, from everyone I know who has a toddler, because now they're developing a little personality. Now they kind of understand what's going on, and now they're rambunctious. Toddlers are those who start to be real risk takers. They want to start moving out of their safe zones and exploring, because now they are mobile. Babies are so great because for the most part you can kind of put them in one spot, strap them down, and they're good. Toddlers, however, mobile. Again, these are the same kind of issues that you're going to experience with infants in terms of like infectious diseases, respiratory problems. Febrile seizures are a big issue in this age range as well, because you have a very poorly developed hypothalamus. So once the body temperature starts to rise, it resets that part of the brain and causes seizures. And once a baby has a febrile seizure, they're more likely to have febrile seizures in the future. Concerns with febrile seizures are that a lot of the times, even if mom or dad has like Tylenol or Motrin on board, it doesn't necessarily control the fever well enough to reduce the risk of a seizure. It's less about the height, like the level of the temperature. It's more about how quickly the temperature rises that causes a seizure. Drownings are very, unfortunately, very common in this age range. Accidental ingestions, right? They're little tiny mobile troublemakers. It's hard to keep up with them. And if you have not secured your home appropriately, you're going to have a child who's getting into a lot of various things. Preschoolers, right, that 3 to 5 age range, this is when they're even more like a little human with like a personality and opinions, and they want to know why, right? Why this? Why about this? They're very explorative, right? They want to learn about the world around them, and that's totally normal, and it should be encouraged, because when a baby or a preschooler interacts with the world around them, this is when they start to learn, right? This is the one of the more formative versions of learning that children start to do, is how they interact with their environment. This is also when they start to kind of develop fine motor skills, so things like tying shoes, or doing buttons, or zipping zippers, right, are a lot more, they want to have that independence to be able to do it. Again, a lot of the same concerns for the first few years of life when you have respiratory issues, vomiting, diarrhea, febrile seizures, right? You're still kind of in that grouping of concerns. But however, your physical injury risks also increase, because kids don't have a really strong concept of danger or what danger is, right? They don't necessarily understand that they can get hurt until they do. And they are fearless, which is also terrifying, because you now are trying to wrangle a fearless child. There was an interesting study, I want to say probably about a decade or two ago. They started changing over all of the the playgrounds. So I don't know anyone who's like in their older 20s/30s or older. When I was in elementary school, we had rocks. Like if you were on the monkey bars and you fell off, you were falling into pebbles. So you didn't do a lot of really crazy things. I mean, you did until the first time you fell on the rocks, and then you're like, that sucks. Let me not do that again. And apparently that's just not good for kids, right? Like we changed all of that over to like this recycled rubber matting that like it's soft and kids bounce and no one gets hurt, right? Except injuries, childhood injuries increased after they started putting all those things down, because kids weren't getting hurt, so they would do more risky like behaviors, right? So like kids hanging upside down from the monkey bars and trying to do flips and stuff. You know, you land on soft rubber, no big deal. You land on rocks, you learned real quick. So it's an interesting way that that public health movement actually kind of backfired. But yeah, little kids, risk takers. Similarly, school age kids, right? So like that 7 to 12-ish age, right? They all of a sudden will be able to be very focused. Okay, and this is part of the reason that we the way that school is, right? It starts to get longer and longer as they get older and older, and they start having more intense learning that they need to do, is because they are able to concentrate, and they're still little sponges, so they learn a lot. Rather than physical, like a lot of, the second you put kids in a group of other children, they're going to be susceptible to various viral infections because they just share germs, which is why the whole let's throw kids back into school in COVID was kind of a questionable decision. But now these children also, as they seek levels of independence, they also start to, again, the risk take, because that's how they interact with their environment and they learn. But they'll become injured by things like bicycle crashes, right? And the problem with bicycle crashes, I'm going to stop share for a second. So right here, this abdominal wall, right? Now think about where bicycle handles go. And if you're a little kid and you crash your bicycle, you're going to take those bicycle handles right into an underdeveloped abdominal wall, okay? Adults were like, hey, I've got a six-pack, right? Everybody's got a six-pack. It's there. It's just maybe under stuff. It's what we tell ourselves. Kids don't. They have a very, very flexible, not only abdominal wall, but their chest wall as well. So they could potentially break ribs and puncture a lung. They could do damage to their diaphragm. They can rupture their spleen or liver lacerations. I had a young girl once. She ran into a car. She didn't get hit by a car. She ran into the car and lacerated her liver. Okay, like emergency surgery. So these are things you need to make sure that you kind of take into consideration when you are evaluating pediatrics, especially in that pre-adolescent age range. They don't have the six-pack that the rest of us pretend we do. All right, let me share again. Exactly. See? I got you. So the problem with preteens or school age kids also is now they're starting to develop puberty, right? They're that 12 to 14 age range. There you get a little moody, right? And this is sort of where a lot of behavioral emergencies and issues start to kind of bubble to the surface. Like if they haven't already been diagnosed with ADHD or like an oppositional defiance disorder, this is where things like depression and schizophrenia and bipolar, this is where they start to kind of come to the forefront because of that massive hormonal swing that really just takes that brain and is like, hey, guess what? I'm going to wash you in emotion. We're going to wash you in uncertainty and peer pressure and body image issues, right? So you might have a lot of, adolescents who are physically okay, but emotionally or mentally not okay. I don't know if anyone remembers being a teenager, but it wasn't fun, right? There was a lot that you have to deal with that you really don't necessarily remember, I guess, if that's the right word for it. You kind of black out parts of like the challenging parts of your adolescence because it was challenging. You also will start to see, students or patients who may be experimenting with drugs, alcohol, sexual experiences, okay? So pregnancy, genital trauma may be also concerns. So, quick anatomy and physiology review. Up until about 8 years old, kids have a big old pumpkin head, okay? It's essentially too big for their body. You have to kind of grow into that, and that sort of starts happening around that pre-adolescent age range. The back of the head is very large as well, so that's also going to create issues when babies fall, because they'll fall backwards. Most of the time, if they're starting to learn, they fall on their butts. But if you have to ventilate a baby, remember when we did BCLS back in the day, you have to make sure that the baby's head is positioned appropriately. Sniffing position is important. That means you might have to pad underneath the baby's shoulders in order to get the airway aligned and in a straight line. Anterior fontanelles, right? That little portion right in the front that allows the baby's head to pass through the vaginal opening. The anterior fontanelle is the last one to close. Okay, test question. Anterior fontanelle is the last one to close. It will be closed by 18 months. I know there are some textbooks that say otherwise, but that is wrong. It is 18 months is the cutoff for anterior fontanelles. When you are assessing a baby, it's very helpful because if you have a bulging or a sunken fontanelle, it can give you a lot of information. Like a bulging fontanelle in the presence of a calm baby may indicate something like hydrocephalus, right? Or increased intracranial pressure. If a baby is crying and their anterior fontanelle is bulging, that's totally normal. One would expect, as an adult, we just get that vein, right? That vein that's like right here. Usually there's some people who have it like right here, right? That bulges when you're like upset or angry and like, you're putting a lot of pressure in your abdominal region. So it kind of goes up. Babies have that anterior fontanelle, so they can express their displeasure with whatever it is that you're doing. Perhaps you are not doing peekaboo correctly. Sunken fontanelles, on the other hand, are a very good indicator of dehydration. Okay, those are the two most essential things that you need to know in regards to the fontanelles for infants. Moving on. Airway. So, the cricoid ring, again, this is one of those test question kind of vibes. The cricoid ring is the narrowest part of a pediatric airway. Other issues when it comes to a pediatric airway is, besides the prominent occiput, which we just talked about, is they have a very small face, right? So it's a very small airway. Their epiglottis is very floppy, and if you don't believe that floppy is a medical term, it's in your textbook, which is just amazing. It's more challenging for babies to clear their airway, right? They don't necessarily have that same mechanism that we do, right? That like they still have that coughing mechanism, but they might not have the lung capacity and the abdominal muscles to good and proper get their airway clear. The trachea also, right? So as an adult, the trachea kind of bifurcates down here. As a child, it bifurcates a much higher. So as an adult, if you're choking on something, we can push it down the right main stem. You still have one good lung. As a baby, if you choke, it's more likely to block the trachea rather than one main stem versus the other. This is up to about 8 years old. Other issues is babies, right? They just get a lot of upper respiratory diseases or infections, right? And those infections can get to a point where it causes enough inflammation or secretions to really create an issue when it comes to the airway. Those little bulb syringes are some of the most helpful pieces of equipment that you'll have on the ambulance when it comes to dealing with a young pediatric patient. Yes, we have the French catheters, but I don't think I've ever seen a French catheter used successfully in a pediatric airway. It's more like down the trach, which is a much more, or the tube, which is a much more effective use of a French catheter. So at least the bulb syringe, it's a little smaller, you're able to kind of manipulate it a little easier than perhaps a Yankauer, and it doesn't produce as much suction and is maybe a little less terrifying for a small child. if you kind of remember the way that the pediatric mannequins have the little teeny tiny lungs, I want you to kind of think of that when you're thinking of how well they are able to breathe. They have little teeny tiny lungs. Okay, so if anything interferes with their ability to breathe, it's going to impact them a lot harder and a lot faster than an adult, right? We have all of this chest and intercostal muscles and diaphragm to really get a good deep breath. Kids don't have that six pack, so they have a harder time getting that, getting good chest excursion. Anything that starts to increase that metabolic oxygen demand is going to make them tired, okay? And kids don't necessarily tripod, right? A lot of times kids will lean back because when they lean back, it opens up their chest more. But again, you have to remember that all of their muscles are underdeveloped. They haven't been doing, they don't lift, bro. So they are not exactly going to be able to sustain a respiratory distress state for an extended period of time. So we talked about cardiac output back in cardiology. Babies are hummingbirds. That's what I'm looking for. They have little tiny hearts that need to pump very quickly in order to move their blood around, right? Granted, they don't have a particularly large body, but they still need to be able to maintain it. This is why bradycardia is such a concern in young children, because they're not moving adequate blood for their end organs. The problem, or the difference, I guess not a problem, the difference between adults and pediatrics is that pediatrics have a really shiny new vascular system, right? When they have like a hypovolemia or a hemorrhage or something to that effect, they can vasoconstrict like champs. Not the way, like adults, not as good at that, okay? We have just more body, so we have less, and we have a larger vasculature, so it's a less potent control than a baby, right? It's a little itty bitty thing. I think this is a really interesting diagram on the bottom where it talks to you about how much blood each phase of life has. So if you are a 9-pound baby, you have approximately 12 ounces of blood. So if you have any sort of hemorrhagic issue or hypovolemic issue, that baby's going to have significantly less blood than they need, right? If you lose a shot glass, American shot glass, is 2 ounces, right? That is 1/6 of their blood volume. That's significant, okay? So, but they'll maintain because of their vasoconstriction abilities, right? Meanwhile, as an adult, you can lose, couple liters of about a liter of blood or so before you really start to look shitty, depending on how big you are. So, you can go and donate a pint of blood without blinking an eye. Babies don't have that, or babies and children don't have that capacity. Right there, that part that they're poking, that's the anterior fontanelle. Okay, that's about right in the top of the head. The baby's nervous system is generally pretty well protected, okay? They have a little more cerebrospinal fluid, and they have up until about 18 months, open fontanelles. So while the fontanelles, if there's a direct hit or direct injury to the open fontanelle, like the brain underneath the open fontanelle, if there is some sort of blunt traumatic force that creates a intracerebral bleed of some type, they won't exhibit the same Cushing syndrome that we will as adults, right? Because their brain has space to go. There's space for that blood and the brain at the same time. Not that I'm recommending that it could be a good thing, but in the event it does happen, there's a little bit of wiggle room, I suppose. Spinal column is a little bit more pliable, which is, again, useful for when they start bouncing around and trying to learn how to walk. So we talked about the abdomen already, right? Especially in the presence of bicycles or other abdominal traumatic injuries. Kids generally don't have as much developed musculature in that region. Liver and spleen are much larger and much more vascular than as proportionally than in adults. Okay, think about it. You got to fit a lot of organs in that little tiny space. Whereas as adults, we kind of have a little more room to spread all those things out. Also, any sort of blunt abdominal trauma can cause damage to more organs than if you are an adult, because they are closer together. We talked about this in the respiratory section a little while ago, that the chest muscles do fatigue very quickly. As an adult, your ribs sort of kind of move upwards a little bit, and they're less horizontal. So the horizontal ribs of children are not particularly good at protecting the little tiny lungs. Again, they're abdominal breathers, right? They don't necessarily recruit those chest muscles to help them breathe, and if they do, they're pretty much in a really bad respiratory state. And because kids are so small, it's really sometimes challenging to hear lung sounds appropriately, because the chest wall transmits the sounds very, very well because it's so small. And they have these hyperinflated lungs because they're just good. They're really good lungs. They're fresh and clean, and new. So you may have a difficult time assessing a pediatric lung sounds. This might be the time when you try to get it very, very quiet. Try and make sure that the kid is not talking while you're listening to lung sounds. Is also going to be a challenge that you may experience. So you need to make sure that the baby's comfortable and, follows directions well. As a kid, we have what's called growth plates or epiphyseal plates. This is the portion of your bone that actually grows. So when we talked about a pediatric, starting IVs on pediatric patients, and we said, go to the IO instead. This is why it's essential that you know where the appropriate placement is, because if you put the IO into the growth plate, you may cause significant complications in the future for the kid. Okay, like one bone may grow more than the other, all sorts of issues. So pediatric bones are also super squishy and soft. Okay, this is why kids who break a bone, like younger kids, again, that 8-year-old age range is kind of where you start to see bones starting to stiffen a little bit more. Young children with broken bones is like 85% of the time is an abuse situation. But then probably about 10% of the time is you have some sort of like rare genetic disease like osteogenesis imperfecta, where they just have extremely or fragile bone syndrome. So those are things you need to kind of take into consideration. Again, it also depends on what bone it is. A lot of kids, remember, they start to become risk takers. If the story is that, Timmy was on the monkey bars and Timmy fell off and now Timmy's wrist hurts, that makes sense. And again, you want to make sure that you're going to do all the splinting that is necessary, because even if he doesn't look deformed, it could still be broken. Okay, but if it's like, my 3-month-old fell off the bed after he rolled over, and now, he have a significantly deformed shoulder or a significantly deformed humerus, that's extremely suspicious, okay? You have to have a certain level of a high index of suspicion when it comes to pediatrics, especially in the trauma situation. Body surface area is essential to kind of consider when you are dealing with pediatrics, especially the little itty bitty ones. Babies are not able to regulate their body temperature well. They are mostly made of water. They're cute little cabbages, okay? Or cucumbers, I guess is probably more appropriate, right? So they don't have this like subcutaneous fat that helps the rest of us who are hiding and protecting our six-packs to stay warm, okay? So they are just they don't have that shiver mechanism to the same extent that we do as adults, okay? Remember we talked about that underdeveloped hypothalamus that contributes to febrile seizures? The same thing goes for chilly kids, okay? If they're cold, their hypothalamus isn't going to recognize it as readily. They're not going to be able to shiver. They're not going to be able to go and be like, I could use a sweater, okay? Like they don't have that cognition level. They don't have that ability to then maybe get up and go, right? Like, again, we talked about little kids and their ability to be mobile. Toddlers might be like, I need my blankie. But, younger children where they're really much higher in the body surface area, they're not going to be able to do that. This is also similarly why burns are so dangerous for young babies, okay? This is also going to be probably one of those very common calls that you're going to encounter is baby pulled something off the stove, baby pulled a hot cup of coffee, and they have burns. That kid should be transported, regardless of what the body surface area of the burn is, regardless of how, like, the severity of it, that baby needs to be transported, because 2 hours from now, when that area, that fluid starts to leak out from the burn area, they're going to get cold, they're going to become hypothermic, and they're going to have issues, okay? So you need to make sure that you take those things into consideration when you are dealing with patients. As much as we're like, oh, babies can't stay warm, like, it also concerns me when you have moms and dads who bundle their baby up like this, but it's like 80 degrees outside. You're like, that kid's gonna die. Also, I'm going to start a petition that if you bring your red-headed children into the sun, you need to have a minimum of SPF 100 on them, otherwise it's child abuse. These poor little kids are gonna crisp up. Similarly to how babies can't regulate their body temperature, they have limited glycogen stores, which is part of the reason that they aren't able to regulate body temperature, right? They don't have the glycogen in their muscles to begin an extended shiver response, okay? So if a baby is sick or has an injury or burns or something to that effect, just like a bad diabetic, their blood sugar is going to plummet. Okay, so if you have a baby who is, injured or kind of just really sick looking, it's a really good idea to get a BGL on them. Okay, because at least if you have a baseline and the baby starts to become more lethargic or altered in any way, shape, or form, you can then you have that baseline vital sign to compare it to, because maybe they're sugar tanked. Right? Maybe they are significantly dehydrated from vomiting or diarrhea, okay? There's a lot of different things that you have to consider. Mom and or dad should have an idea of how many diapers the baby goes through a day, okay? If it's more due to diarrhea, then you might want to be considering a fluid bolus, right? And again, it's going to depend on the severity of the patient's presentation. But there's a significant possibility that if baby is, vomiting or has bad diarrhea and not able to keep anything down, that, they're going to need an IV. But that's also a nice job to let the hospital have. Yes, go ahead. It's going to depend on how, if you have, well, first of all, it's going to depend if you have access, right? I know that a lot of the protocols are switching over for babies right now in the city, it's D10 or D25, which is an age-dependent dose. But as you're moving towards the unified protocols, they're moving towards D5W because it is a little more gentle in terms of the sugar spikes that it causes. So if you have access, you may want to do that, because if the baby is altered or not acting right, that's hypoglycemic for them. So it's kind of the same way that if you have like a diabetic who's sitting there with like a blood sugar of 100 and, usually their sugar is 300, then you might want to consider treating it. Again, it's really going to depend on whether or not your patient has, or you can get access on the patient. You're welcome. Good question. So one of the things we kind of teach you when it comes to pediatric assessment is that it's going to look a little bit different than an adult assessment. Mostly because, one, depending on the age of the child, they may not be a great history taker or a historian. And two, the younger they are, the more likely they are to be kind of nervous about you, because you are a big stranger and you're scary. So a lot of the times, right, remember younger children, we start from the toes and we work our way up. Other things that are really significant when it comes to dealing with pediatric patients is what is the environment that they're living in, okay? A lot of the times, depending on the age of the child, they're not going to be able to stick up for themselves, right? If there's some level of child abuse in the home or neglect or something to that effect, this is going to depend on your ability to do a scene size up, right? Are there chemicals, like household chemicals or medications all over the place? Is the home clean? Is it safe? Is it like one of those it's under construction but it's never going to get finished kind of homes? Is it a hoarder house? There's a lot of things that you can evaluate. And we talked about this last week. You are in a position of power as a pre-hospital care provider because you see things that no other medical professional is ever going to see. So it's your job to be, have a good attention to detail. Also, the interaction between the parent or the caregiver and the child is important, right? We talk about this during lifespan development in the beginning of this class, is that children should have a secure bond with their caregiver. If the caregiver seems dismissive or non-caring about the child, or the child is avoidant of the caregiver, that's a pretty big red flag. So, and this is especially for the younger children, does a child have good movement, right? Are they kicking and crying and acting age appropriate, or are they kind of limp and lethargic, okay? One of those is good and one of those is bad. Does the child, are they aware of the things going on around them? Usually if you speak or you like make noise, usually you will draw not only a child's attention, but an adult's attention at the same time. You know what I mean? Like, but this is also one of those things. Does the baby have any sort of disability, such as being blind or deaf? Okay, so if you walk in and you have a child who's not acting appropriately, but they happen to be deaf, then that's less of a concern than if, you walk in and the baby just doesn't care. Okay, right? They're experiencing a completely different environment than an able-bodied baby. Consolability. People with kids will know this probably a little bit better than those who don't. But I think we all kind of recognize you pick up a baby and usually they kind of like, okay, and this is cool. This is better than where I was. I'm happier now. Sometimes you have a baby who's just colicky, right? They're like just kind of grumpy. There's something bothering them and you haven't figured it out yet. So they may not be the most consolable. Speech and or crying, right? That's important. Does the baby have a good cry? And again, this is going to be dependent on the baby. There's some babies who are just super mellow, right? And this is like a good question for a parent. Like, is this their normal cry? Because if they're kind of like, meh, and like low key, but that's normal for them, and mom and dad have already talked to the pediatrician about it, then I'd be less concerned than if you have a child who's usually very boisterous, who is not interacting, doesn't, engage with the environment, and doesn't cry strongly. This is super useful when it comes to dealing with babies, okay? And smaller children, remember that 8-year-old range. So the pediatric triangle, okay, this is really the three things that you're most focused in on when you're talking to or you're assessing a child. So if you have a child who has a good appearance, they have good peak circulation, and they don't look like they're really working to breathe, that's a stable baby, right? If their work of breathing is off, it's a respiratory problem. If their work of breathing is off and they kind of look blue or gray or mottled, respiratory failure. Shock is either poor circulation or poor circulation and poor appearance, right? So again, that mottled skin tone, they maybe look blue or gray or lethargic. You want to consider shock. If they just look a little off, it could be a CNS issue or a metabolic issue, because a lot of times diabetic kids, right, they're not, it takes a little while for it to build up and you kind of notice, oh, something's wrong. And if all three are a mess, it's cardiopulmonary failure, right? You're going to be doing compressions, you're going to be ventilating this baby. Various considerations that you need to take for each portion of your ABCs, okay? Airway, I think we covered all of these. If you can ventilate or suction an airway, you want, for the most part, to try to stay with BLS procedures for most pediatric situations, okay? You don't want to sit around and futz on scene. You want to move, okay? This is like, when you work in the city, you'll see this too. Like, cops are almost always the first people on scene of a pediatric anything, okay? They're always looking for that save, that cardiac arrest save. But they're really good also that if their baby's really sick, they will sprint it out to your ambulance before you can even park. So kind of keeping that in mind, that you should be always moving with a baby or a child, is kind of something you should always have in the back of your head, okay? Moving is good. Breath sounds, right? If you have a hard time hearing the breath sounds, you might want to try to move to a more quiet environment. How is their breathing? One of the most dangerous things that you can see with a baby or a child is the head bobbing, okay? When they start to do the head bobbing, they're starting to get tired, okay? That means that maybe you need to ventilate that baby or child. Capillary refill is extremely useful in children, not so much in adults, to assess circulatory status. Any sort of visible hemorrhage you should take very seriously, because remember, we talked about that soda can or that 2-liter bottle, depending on how old and how large that baby is or that child. Obviously, younger children who have perhaps poor English language skills, you may want to be getting the history from the parents or a caregiver. A lot of kids don't necessarily know their medical history because, again, they're little kids. They don't have a care in the world. A lot of times you will note though, that young children will know if they have a severe allergy, okay? Because they'll be like, I can't have that, right? Kids are good like that. If they, are told that there's some level of danger, they're usually pretty good. But when you're talking to a child, or you have a child who you're assessing, don't pretend that they're not there. That's like a pet peeve of mine. You should interact with the child, especially if they're of the age where they do understand, like, that there's something going on. 2 or 3 and up, like, give them attention. It's like the same pet peeve that, like, when you have a patient, like an elderly patient who perhaps is a poor historian, or is even a great historian, but their adult child has called for them and they're going to tell you the story and they're not going to let their parent speak because they don't know anything anymore. That don't take away someone's personhood like that. Make sure that you acknowledge the fact that they are the patient and should be respected appropriately. There are definitely going to be questions that you're going to probably want to ask separately, such as sexual activity, possibility of pregnancy, drug, alcohol abuse or use, and child abuse, right? Those things, you're probably not going to get an honest answer in the presence of a parent. Maybe sometimes, like, some kids have a good relationship with their parent like that, where they can be open and honest. A lot of them, not necessarily. The patient's presentation is going to dictate how much time you are going to assess on scene, right? And we talked about this, always be in motion with a child. Older children, eight and up or so, you can treat them the same way you would do an adult assessment head to toe. Younger children, like that toe, especially babies, right? Toe to head, to kind of make them comfortable with the fact that you are touching them, and you are not a human that they know. Key areas, right? Your airway, breathing, circulation, always essential. But this is not necessarily, like, this is not a stay and play. This is like a try to always be, you're not like loading and going, but you're not staying and playing, like a relentless forward motion. There we go. I did. Yep. So another significant difference between pediatrics and adult patients. If there is a cardiac arrest in a child, it is 99.9% of the time due to a respiratory issue. Pediatrics are significantly more affected by hypoxia than adults because they don't have the same residual volume that we do as adults. They are unable to maintain that work of breathing in the same way that us with those six packs are able to. Again, these are some signs and symptoms that a patient or a baby or a child is in respiratory distress. A lot of them are very similar, right? Retractions. If you have an adult who has retractions, you're going to have the same issue, but you need to lift up the shirt, okay? A lot of the times you see EMS get a baby, get a child, and they just kind of put them on the stretcher. All right, let's go. Lifting up the baby's shirt is important. I had a job once on one of my rotations where we had a kid, and mom said, oh, he's having an allergic reaction. I gave him banana or whatever, and now he's, he had like a rash. And I was like, okay. And looking at the baby, no rash. Pick up the shirt, hives all over the chest. And the medics I was with weren't going to do anything. Like, all right, cool, let's go. I'm like, we need to do something. Like, he might not have like wheezing or anything right now, but he's got significant hives. He's, who knows what level of allergy this baby's dealing with. So we called and we got Benadryl. They actually gave us Benadryl, which is kind of amazing. So you need to make sure that you're doing a thorough assessment, okay? Retractions are not noticeable under clothing, adult or pediatric. I mean, adult, you can see if like it's like a right here in like this supraclavicular region, right? You can see some retractions. Babies, you aren't. The retractions are going to be all intracostal. You're going to have just significant notes of those ribs. That's the word I was looking for. Nasal flaring, right? So we talked about how the pediatric airway is significantly smaller. As much as an adult, you're like, what is a nasal flaring going to do other than like signify my displeasure with something, right? I don't know if anyone else does that. Babies actually can increase the size of their airway by nasal flaring. It seems like not a lot to us, but for babies, it can be significant. Head bobbing, we talked about, is really bad. Cyanosis, okay? And I'm not talking about like the newborn acrocyanosis where their hands and legs are kind of bluish, like full like cyanosis. Baby is blue, baby is grayish, okay? These are signs of respiratory distress that are important to know. If the baby starts to continue to deteriorate into irritability or lethargy, where their breathing starts to go from very fast to very slow, bad sign. That's the gateway to respiratory failure, okay? And if you don't treat respiratory failure, they will go into cardiac arrest. Similarly to adults, right? If you don't fix respiratory failure in adults, they're going to go into cardiac arrest. You might have a little bit more time to futz around and like be like, oh, let's get orders to intubate with an adult. You don't have that same, grace period with children. They'll be really, really good until they fall off the cliff, and all of a sudden you're standing there like going, oh no, I have to do compressions. Okay? Aggressive ventilation and airway maintenance, right? So suctioning, airway positioning is essential, okay? even a mild respiratory distress, okay? Don't let it progress to severe respiratory distress. If you can give them oxygen, if you can help them sit in a position that's going to allow them to breathe better, then you need to do that, okay? Again, not significantly different than, helping position an adult, but you have to be a little more proactive in the situation. Foreign body airway obstruction, like super, super big deal in like 80% of 3-year-olds, right? Like a lot of them, kids love little things, and they love to put little things in their mouth or their nose or sometimes their ears. In the event that they do swallow something, or especially little kids with little tiny new teeth who are learning to eat solid foods, okay? Grapes and hot dogs, super dangerous, okay? Because they're slippery and they're large. They can block an entire airway and be very hard to get out, right? Most of the time, if a kid's still moving some level of air, you just want to let them sit and not be agitated, and you're going to keep a very close eye on them, okay? If it does progress, right, we do our chest thrusts and back slaps, McGill forceps if, it absolutely isn't working. One of the reasons that BIC has put a hole in the end of their pen caps is for choking children. So, the crystal pens with the pen, the pen cap, because everyone uses clickies. Clicky pens are so much better. But those pen caps actually have a hole in the end so that in the event that a child does put them in their mouth and end up with a foreign body airway obstruction, that air can still flow, which is kind of wild. Yet another public health. Speaking of, there's a Lego piece. Okay? You have a kid who all of a sudden, and this is almost always on the REMAC exam, you have a child who mom calls 911 saying that all of a sudden the baby started having a hard time breathing. You notice a number of small toys in the living room. What is your first, differential diagnosis? It should be a foreign body airway obstruction, okay? It's just one of those things. It's like, if you leave a child unsupervised for a little bit and then all of a sudden they're having a hard time breathing, probably a Lego. It's important to kind of ensure that toys are age appropriately sized for kids. Again, little ones, mouths, that whole Freudian thing. Croup, right? So we talk about a lot of these things kind of from BLS. Croup is usually a viral infection of the upper airway. Tis the season for croup, okay? It's going to start popping up now. This is the kid who has that bark-like cough, okay? It's usually in the middle of the night. You're working tour 1, you just got to your 89, and you're sitting there like, yeah, I'm gonna watch some Netflix. And then you get the pediatric call, okay? It's commonly croup, okay? The best thing to do for croup is to move the child into cool air, okay? And you'll notice if you're in the house and it's a little warm in the house, if anyone does rotations in Queens, you're going to be amazed by the temperatures that some of these apartments can achieve. You'll take the kid out of this really warm, hot, kind of stuffy apartment and out into the cool night air, and the baby's like, oh, I'm good. Oh, this is so much better. No, I'm good. I don't want to go to the hospital. You're like, you're 2. You're going to the hospital. But you'll notice like that or in the shower, okay? A lot of times the expert level of parents will take the baby who has croup and bring them into a hot and humid, like a hot, humid shower to kind of help reduce the inflammation, a little easier for them to breathe. I'm going to tell y'all about a fun story about croup and epiglottitis in a second. Kids who have epiglottitis are very sick, okay? It can occur at any age, and this is where my funny story is going to come in. Most of the time, these kids are going to look very still, okay? They're going to be leaning forward, drooling, because their epiglottitis, the epiglottis is so swollen that they can't swallow, okay? You need to make sure that you don't agitate them. Okay, again, this is all of a sudden they wake up with a high fever, like a difficulty swallowing, a sore throat, and that drooling. Okay, whereas croup, on tests, croup is that bark-like cough. Epiglottitis is drooling, difficulty swallowing, high fever. Okay, that's usually the kind of the delineating factor between these two very common diseases. So, once upon a time, back when my husband and I were first dating, he was working. He had a really rough week. He worked a double at Jamaica, and then he picked up an extra shift at Flushing because they couldn't fill the truck. So while he was working the double at Jamaica, he had 2 pediatric arrests. And I was like, you should maybe not go to Flushing. Like that, are you okay? He's like, yeah, no, I'm good. So goes to Flushing and has another pediatric arrest. I'm like, seriously, dude? Like, get off the truck for a week or so. But the problem with the last pediatric arrest was it was a small child who had a viral infection, and unbeknownst to the parents, that this kid was like probably about 18 months old. Unbeknownst to the parents, the kid had a cardiac abnormality. So he had this raging viral infection, which actually ended up attacking his heart and causing his death. My husband, bless his heart, decided that mouth-to-mouth was definitely the best answer for this pediatric who is in cardiac arrest. And I was like, you know, there's BVMs on the bus for a reason. He's like, I panicked. I was like, And he was stricken with a weird combination of strep, croup, and epiglottitis from doing mouth-to-mouth on this child. And he was sick for like a month and a half. His tonsils were enormous. They were touching. Like, it was so disgusting. And I was like, I'm gonna make you some soup. And then, yeah, I was like, I'll make you some soup, and I'm gonna sit on the other end of the couch, and we're gonna watch some Netflix and chill. But like, no, literally chill over there with your germs. So that's, he hates when I tell that story, but I'm like, well, why'd you do mouth to mouth on a baby? He's like, it was a baby. I'm like, self-preservation, dude, self-preservation. Had another one of my instructors for EMT did mouth to mouth on a neonate, and the neonate happened to be HIV positive, and he had to do the whole gambit of prep after doing that. So with those 2 situations, if you ever get on an ambulance with me and I'm like, a pediatric arrest, allow me to get the BVM. Don't judge, okay? I know people. Moving on. Bacterial tracheitis is commonly a secondary infection. It's more on the rare side. It's an infection of the trachea, obviously, as given the name, that is usually secondary to something like croup or epiglottitis, okay? Very similar presentation, but kind of differentiates one from the other is that the baby's probably had croup prior to the secondary infection. Again, we are not necessarily going to be diagnosing this in the field. Maybe croup, maybe epiglottitis, bacterial tracheitis. Frankly, you're probably going to end up treating it very similarly to croup or epiglottitis, because you're going to make sure you oxygenate the baby and that you don't agitate them and that you keep them calm, okay? And keep a really close eye on them, because this could become very serious where you need to start ventilating, right? Or you need to start doing something a little more aggressive. So, asthma. Go ahead. They'll probably have a cough. It might be cough like bark-like. The thing is, it's usually mom is going to be like, yeah, the baby had croup like last week and we thought we were better and now he's sick again. Yeah, that's kind of your line in the sand between one and the other. Yes. So basically, bacterial tracheitis is sort of a opportunistic bacteria that takes advantage of a weakened immune system, because the viral infection weakened it, and now the bacteria has come in and been like, you've made it so lovely here for me. But yeah, you'll have a lot more mucus and pus with a bacterial infection than a viral infection. If that makes sense. Cool. All right, asthma. So, technically, in the world of pulmonology, you are not allowed, quote unquote, allowed to diagnose a baby under the age of 3 with asthma. Until that time, it is bronchiolitis. Okay? Yet again, here in this magical world of EMS, we're not diagnosing the patient as one or the other. We are going to be ensuring that the baby or child, I keep saying baby, just know I mean baby or child, that the baby is being oxygenated and that you are making sure you keep a good eye on them, okay? If you hear wheezing, you can treat it with albuterol, right? In the pre-hospital care setting, if it's a kid who's wheezing, it's either 1, asthma or bronchoconstriction, or 2, a foreign body airway obstruction, okay? Because every once in a while they will, obstruct their airway with something that makes a whistly noise. It happens. So if you have a kid who's in that younger age range who they're like, well, they think he has asthma, treat it as asthma, okay? Use the wheezing protocol that we have. On the BLS side, is it wheezing? Then give it albuterol. On the ALS side, it's, if it's wheezing, give it albuterol and maybe half of a dose of ipratropium, okay, depending on the age. Again, that 2-year-old age is kind of essential. Check your protocol. Because pediatric asthma does have extra rules to it than adult asthma. Young children who have this, let's just back up the truck real quick. In the New York City school system, pediatrics, young children, any children, are not allowed to carry their own inhaler, which is ass backwards. So you're telling me that a small child who has a diagnosis of asthma and has been taught how to use their inhaler and can have an exacerbated event while at recess or in gym or, I don't know, sitting in class trying to take a math test, is not allowed to self-administer their own medication. Nay, they must now get up, get a hall pass, get themselves down to the nurse's office, which may or may not be open, because let's talk about budget cuts and how they have affected the way that school nurses are able to be employed. Or, hey, maybe the school nurse happens to be down at the gym because someone fell and skinned their knee, right? How does that make any sense? So, if you happen to be responding to an asthma call in a New York City public school, anticipate it being worse than it should be, okay? Kids also have this kind of tendency to not notice when they start to wheeze. Asthma attacks in kids can kind of be like days to weeks long. Adults too, but usually adults are like, yeah, no, that's not right. I've got experience with my asthma. I know this isn't good. Kids are like, it's fine. I'm just going to go run around. And they don't notice. So you might have a kid who's coughing. Just coughing, okay? You might not hear wheezing, but they have a history of asthma, and they're like, I'm having a hard time breathing, and they just have like this weird kind of dry cough, okay? You might have a kid who's gone all the way to a silent chest, okay? Because again, school nurse issues. So just keep it in mind that when you are assessing a kid who has a history of asthma, to be a little more, I guess, prepared to act. Okay. I would even say, even if you don't necessarily hear wheezing, be prepared to maybe give them albuterol. Okay. Because they might be more serious than you know, because that kid might not have noticed when they started having an asthma attack like a week ago. And here we go, bronchiolitis. Usually bronchiolitis can be caused by a viral infection. Okay, where they have some level of fever involved, or it can be considered, quote, bronchiolitis as their, like in their discharge paperwork, even if they don't have a fever, but those kids will be asthmatics later on, okay? Bronchiolitis does not necessarily respond to bronchodilators. I know this says it does not, period, but there are some, again, remember, you're going to take a 2-year-old to the hospital or the pediatrician, and they're going to say, for the first 2 years, oh, it's probably just bronchiolitis. And they're probably going to give them steroids and as an inhaler anyway, because hey, it might actually just be asthma. So pneumonia. Pneumonia, I want to say, is probably one of the most significant things that we deal with in the pre-hospital care setting, like infectious wise, because it affects everyone pretty equally, adults, children, etc. And a lot of the times people don't know that they're sick. Walking pneumonia is super, super common, okay? So like the little kids, they might have like a fever and kind of a little bit difficulty breathing, and their whole lung could be full of pneumonia, right? They're pretty resilient, right? In the older adult section, you still have issues with pneumonia. This is maybe also caused by aspiration issues, right? Because as you get older, if you don't have your own teeth, or you're not going to chew food as well, the muscles in your throat start to get weaker, so you might have that, like the old people, like the old people, like 90, and they eat and they're always coughing a little bit. They're aspirating, okay, and they're at an increased risk of pneumonia. Bronchitis has the tendency also, if it is left untreated, it can turn into pneumonia as well. Okay, so you may or may not hear the crackles in a child's lungs. Again, going back to the transmitted sounds, depending on how old that kid is, right? So you may or may not hear crackles or rhonchi, but they might have just might present with respiratory distress and a fever. Okay, and that's a kid who needs a chest X-ray. Pertussis and or whooping cough. Airborne droplets. Okay, that's how it spreads. The biggest problem with pertussis and little kids is that they start getting into this coughing fit where they're like whoop whoop whoop, and they just keep coughing and they can't get enough air in, and they actually become hypoxic because of this repetitive cough that pertussis causes. They can also end up with a pneumothorax because, again, little tiny fragile lungs, very high pressure coughing, can cause issues. Rib fractures, maybe in older children. Again, kids have very squishy, flexible bones. Pertussis kills a lot of infants. This is actually one of the vaccination pushes in the United States, is anyone who is going to be coming in contact with a newborn, for example, mom and dad, grandparents, etc., they're encouraged to get the pertussis vaccine in order to prevent spreading it to the baby, okay? Because while, mom and dad might be like, oh, this is an annoying cough, baby might become hypoxic and go into respiratory failure. So, vaccines are trying to help prevent bigger issues. That's the whole concept. Any thoughts or questions before we move on to shock? Cool. Uh-huh. I would agree with that. From a liability point of view, that's troublesome. There are definitely some medications that are, like, oh, you're going to push calcium, it's an amp, and you're just pushing the whole tube. I get it, and if you have someone who, and I also understand where some departments or some medics might take a little liberties where it comes to like, oh, I know this person's in medic school, I can maybe treat them like another set of hands. I understand where that mindset comes from. But again, the second something goes wrong, that's your fault. That's your problem. So is that a risk that you're willing to take? I guess is the question. Yeah. Yeah, exactly. So, and again, it also goes back to documentation. Are you going to document that you were not the one administering the medication? I would hope not, because that's foolish also. Um, yeah, that's a little complicated gray area there in terms of what people do. Yeah, no, that's why'd they go with a humorist then? Why would they go with a humorist then? So the protocol in Suffolk is that you are allowed to do a humoral IO. I would not suggest it in a morbidly obese woman because you are not going to be able to find landmarks, A. B, that's a lot of tissue. Granted, the humeral IOs are longer than the tibial IO needle, but that's still a lot of tissue, okay? Especially, and here's a little anatomical gender thing, women have a larger patch of fat over their deltoid than men do. This is why y'all get cut and the rest of us just kind of go, there's a tricep in there somewhere. I would not necessarily recommend a humeral IO. I mean, if she had no legs, sure. Like, I've been in that situation. I'm like, well, guess we're not getting an IO on this guy, but we didn't have a humeral IO to use. So, no. Yes. Yeah. Mm-hmm. No. No. The only people who allow sternal IOs, as far as I'm aware, is the military, because those guys are savage. There's Amelia in the corner. Um, because so a sternal IO is a completely different needle than the humeral or the other IO. It's like a ring, and it's got a bunch of needles, and it goes right into the sternum. Because again, remember the sternum is relatively thin. So if you have a big old needle like this, you're gonna go right through. May as well just put it right in the heart, right? Whatever. So no, as far as I know, I don't know of any agencies that would use a sternal IO because now, um, you also have the concern as if that patient is in cardiac arrest. How are you going to do compressions with a sternal IO? Amelia's like, let's make him walk it off. You're dead. It's okay. Walk it off. Yeah. No, that's a great question. And yes, again, the morbidly obese issue is, I don't know why that was a consideration. I don't know. I don't. I don't know. Suffolk. It's like the wild east out there. Oh, heavens almighty. Suffolk. It's very, very Cape Cod. All right. Now that I wrap my mind around that one. So shock in pediatrics, is again just like any other shock. It's an inadequate oxygen delivery for the metabolic needs, and there's a variety of different shocks. In children, you're not necessarily going to be seeing cardiogenic shock as commonly as you're going to in the 80-year-old age range group, right? Kids generally have a relatively new, shiny, smells like a new car heart. What you're going to have is hypovolemia and hemorrhagic issues, right? So, and this is something that you can do as an adult also, is you can actually calculate about how much blood volume you have. In a child, it is 70 to 80 milliliters per kilogram. So if you have a 5 kilogram baby, like infant, newborn, that's like 350 milliliters of blood, right? Go to your nearest ambulance and take out a 250 bag and go, oh, that's about it, with a little bit more, right? Not a lot of fluid floating around, so any change in that level is going to be significant. The baby and child are going to be able to maintain a normal blood pressure until they can't no more, right? And that's mostly through vasoconstriction. And you're not going to necessarily see the mottled skin of that vasoconstriction and that shunting until like it's really kind of serious. Always have a high index of suspicion when dealing with a child, okay? Especially when it's just not acting right and you suspect of having shock. We talked about this already, where body surface area and an inability to shiver causes a significant increase for a risk of hypothermia. When I see people walking around with their babies or their young children and it's kind of chilly out and that kid is not bundled, I like my back gets up because I'm like, you're not a good parent. So now if you have a kid who is in hypothermia, they can also have secondary shock and issues due to like metabolic acidosis, right? Because if you start becoming hypothermic, your heart rate starts to go down, which means that your oxygen demand increases because you're not able to move blood around as well, which means that you switch from aerobic to anaerobic metabolism, right? So it's a vicious cycle that of shock. And because of all the acidosis kind of associated with hypothermia, when you do try to resuscitate, and this is for children and adults, the more acidotic you are, the less effective epinephrine is. Epinephrine is an acidic medication, right? So if you put an acid in an acid, it's kind of like, that's cool, whatever. Like, right? You're just making the patient more acidic and not actually helping in the resuscitative effort. Remember we said babies are hummingbirds. They do not have cardiac reserve, okay? Stressful situations like that require their heart rate to be elevated is very demanding for their little tiny systems, okay? So they are not able to compensate well because they need more oxygen, but they have tiny lungs. They need to improve their body temperature, but they can't shiver. They are very anxious, right? Because now you have all this epinephrine flooding their system, but their heart isn't going to be able to keep up. If you think about where the like level, like the cutoff for SVT is for an adult, right? We have like 180, 150, 180, depending on which books you're reading, is SVT in an adult. Kids can be as high as like 220 or more, okay? I had a pediatrician, I had a kid who was in a SVT at 280, and the pediatrician at the hospital was like, he's good for now. I was like, what do you mean he's good for now? he's like, oh no, he'll be able to maintain that for a while. And I was like, I disagree, right? But that at that point, they also needed to ensure that it wasn't a compensatory hypo or tachycardia, that it was not due to hypotension or hypovolemia or other shock, right? So they'll let them ride in the hospital under careful supervision while they make sure that everything else is adequate. Yes. It doesn't. It doesn't. Because there's no grace period with pediatrics. They're either normotensive or severely hypotensive. You know, like that falling off a cliff kind of vibe. That permissive hypotension, it doesn't exist. Like they're either one or the other. If that makes sense. Okay. Vital signs sometimes are really challenging to get on kids, especially really little ones. Sometimes they wiggle a little too much, right? So a lot of the times when it comes to blood pressure, we don't commonly get blood pressures on babies less than 3. Everybody has like a new laser thermometer now, so body temperature is nice and easy to get. Cardiac monitoring is essential, okay? It's really useful, especially for an EKG, because you can look at the electrical and then you can also listen, right? So if you can't palpate a pulse, take your stethoscope and listen to their heart, okay? They should be lub-dubbing. Nail beds, right? That is essential to also check, right? Because little kids, you're going to see their level of circulation really well through the nail beds. If you have a child who is in a bradycardic rhythm, okay, again, remember, use that like 8 years old as like a determination. Bradycardia in pediatrics is very commonly a pre-arrest rhythm, okay? The compensatory mechanisms have failed, and the baby is not just circling the drain, they're going down rapidly, okay? This is why when you do, we did this last week, when you have resuscitation for neonates, if they are at a heart rate of 60 or less, you start doing chest compressions. We don't let them get all the way down to an actual arrest rhythm before we start intervening. In young children, vomiting and diarrhea are most commonly what causes hypovolemia. It's, again, remember, teeny tiny bodies, teeny tiny blood volume, so it can happen relatively quickly, okay, like overnight, especially if a kid has a lot of the vomiting and diarrhea issues. What else? 5% more body weight. Again, you're not necessarily going to be measuring that. You're going to probably be listening to mom, dad, or caregiver in terms of how many diapers were used, or how much vomiting was occurring, etc., etc. Blood loss is also significant, right? Small bodies, small volume, so any blood loss is considered significant, can be considered significant. If you do start an IV fluid bolus, it's usually 20 milliliters per kilogram, and enough to kind of maintain mental status. Whereas in adults, we really want to make sure that we don't flood the lungs. Pediatrics are usually tolerate the fluid a little bit better, but that does not mean that you're not going to make sure that you don't fluid overload them, okay? So start with a 20 milliliter per kilogram bolus and go from there. 3 different types of distributive shock that are possible for any age group, right? Septic, neurogenic, and anaphylactic. Anaphylaxis in children is commonly a little more scary because it is new, right? especially if they're really little. So they may not have an EpiPen. They might not know what has caused the anaphylactic reaction, right? Especially when they're in that teething phase and they're starting to eat new foods. They could eat something that all of a sudden just sets them off into an anaphylactic reaction. Neurogenic shock is, I want to say, probably a little less common in really little children because, again, that's like a spinal trauma issue. Septic children, though, will look very, very, very ill. The problem with distributive shock is that the fluid leaks from the vasculature, right? So even if you do happen to give a fluid bolus, it's still going to leak out of the vasculature. There needs, like in terms of septic kids, they need antibiotics. Anaphylactic kids, they need the epi, they need the steroids, they need all of those things to kind of help fix the leak in the system. Very. Yeah, it's equivalent to an IV, and it's going to be a lot more effective, especially in the very small children. Again, remember 8 years old or less. And honestly, with the IO, I would say even like infants, because there are plenty of older children who you'll probably be able to get like a 22 or something in. It's very effective. IOs, when done appropriately, and not put into somebody's morbidly obese lady arm, are very effective. So heart failure, commonly heart failure, again, is not necessarily due to the fact that this kid has had a heart attack or something to that effect. It's usually because of a congenital heart disease or cardiomyopathy. And we talked about those a little bit last week in terms of congenital heart disease. Most of the time, except for maybe, viral myocarditis, which again is relatively rare, but can be caused by croup or another like strep throat or something that has spread. Commonly, mom and dad know, right? This kid is a very sick kid. Okay, it's most of the time not uncommon. Kids who have yet to have been diagnosed with heart failure tend to have syncopal episodes. Okay, that's usually the first sign that there is a cardiac issue in a young child. Well, they'll be running around, they'll be happy, and all of a sudden they're poof, just out. Okay, their heart is unable to keep up due to cardiomyopathy or the congenital heart disease. Okay, so any younger child who does have a syncopal episode, I would highly recommend making sure that when you talk to their adult, that you make to see if they have any sort of congenital heart issues. Common dysrhythmias in pediatrics, sinus tachycardia, right? And remember, sinus tachycardia for pediatrics are different ranges than they are for adults, right? Because our vital signs change as our heart develops and becomes stronger. So sinus tachycardia is not over 100 in children, it's over 120-ish, sometimes over 150 depending on the age, okay, right? Because a newborn or a young infant, their heart rate should be about 130. So SVT is up in the 200s, bradycardia, anything less than 6, well, again, age dependent, less than 100 in the really young, less than 60 in the 8, right, that 8 and up range, and asystole, which is just not something that one wants to do. Bradydysrhythmias, so you have a number of different reasons that a child can be bradycardic. Again, commonly the number one reason is a hypoxic state. If a child is bradycardic, they're going to have poor perfusion. Okay, they're just not able to compensate. If there is something structurally wrong with the heart, such as cardiomyopathy or a congenital heart defect, that's considered primary bradycardia, whereas secondary bradycardia is due to something else, such as hypothermia or hypoxia, etc. Here is a fun algorithm, right? Just like in adults, you're going to check your H's and T's. Okay, you're going to make sure that there's no underlying cause for the bradycardia that you can fix. Commonly, oxygenation. Okay. look at your protocols for more specific treatment paths, but this kind of sums up the whole gist of it. PEA, right? You have a patient who's in cardiac arrest, but they still have some electrical motion. Again, just like with adults, H's and T's. The number one H that you should have on your list is hypoxia with all children. Again, trauma, tamponades, hypoglycemia, hypothermia, all of these things are also going to affect children differently than they will adults. But you look for the underlying cause and try to fix it. It doesn't change the way that you are going to treat this child. You're going to do compressions and ventilate and go to the hospital. So here we go. Non-arrest, most common non-arrest dysrhythmia during childhood, SVT. There's a fun test question that occasionally pops up. This can cause instability in infancy. Again, a lot of pediatricians will kind of let it ride. And the differences between SVT and sinus tachycardia is the patient's history and the heart rate, right? So a patient who's got sinus tachycardia might not be as irritable as a baby or child who is in SVT. Infants, 220 or more. Children, 180 or more. Adults, 150 or more, right? Okay, so those are your delineating lines. Remember, kids and infants, little hummingbird hearts. Adults, not so much. We got the Brolic heart that just doesn't want to work that hard. Here's another example of the algorithms that you guys are going to see. You're going to see these in PALS, okay? But here's a preview. A lot of the protocols that we have are based off of AHA, okay? So this should look familiar to your city protocols. VTAC and VFib, commonly not an issue in children. For the most part, if you're going to be seeing VTAC or VFib, it's due to R on T phenomenon, right? When they get hit in the chest at the inopportune time while playing sports, okay? Other issues could be, drugs, etc., but for the most part, you're not going to see this in the younger children, okay? Synchronized cardioversion, as per like the same thing as with adults, you're going to do VTAC with a pulse gets immediately synchronized cardioversion. Here's another whatchamacallit for you, algorithm. This is also really helpful for adults. It's very similar. For the most part, a lot of the time, if you are going to terminate resuscitation, from a psychological first aid point of view, it is advised that you perpetually consider transportation. Even SIDS patients, even if they've, they're in rigor or something to that effect, there's a possibility that transporting the patient will allow the parents that level of closure. Okay, and obviously, if it's like a crime scene or really bad rigor, you might want to just pronounce there. But just keep it in mind, right? That if you were a parent and you had to deal with some sort of significant issue with your child, would you want any doubt in your mind that everything was done for them? So, if there's any doubt, just transport and do your cardiac arrest protocols. One of the most important parts of patient or pediatric patient care is involving the family, okay? And this pops up as a test question pretty frequently, that, they'll ask, okay, so you're going to do this, this, and this for the patient. What are you going to do? What's your next step? It should be, a lot of the time, it's advise the patient's family of what you're doing, okay? It's sort of similar to how when you're treating an adult patient that you want to make sure that you tell them what's going on. you have to involve the family members when it comes to a pediatric patient. So in terms of stabilization, the most important thing that you're going to do is oxygenation, right? For the most part, a lot of the pediatric calls you're going to deal with are oxygenation related. Maybe some trauma and injuries, but you are not doing anything really wildly over and above BLS, okay? Even in the protocols, if you look at the protocols that we have, you're going to do a really high quality assessment while you're moving, but you're not going to sit around and you're not necessarily going to start an IV. You're not going to, do, medication administration or EKG. You're pretty much doing most of these things while you're moving. Most of the care is on a more BLS level, with maybe some just accentuations here and there. Meningitis, okay, this is very common in younger children and then older children, right? So I don't know if anyone went away to college, but when you go away to college, they make you get the meningitis vaccine. Part of the issue is living in close quarters, and that airborne exposure. Very similar to COVID, right? Bacterial meningitis is much more deadly than viral. Viral is self-limiting, where the baby and or child is going to have a high fever and some vomiting, maybe some nuchal rigidity, right? That's that neck, rigidity in the neck where they can't bring their chin down to their chest. Again, bacterial meningitis will have a much higher fever involved and altered mental status, etc. So it's common practice that if you have some sort of have a child who has any of these, that you should ask if questions about nuchal rigidity, high fevers, etc. Again, here is some of the two assessments that you can do in terms of for checking if there is nuchal rigidity. If nuchal rigidity is present, it's like a 95% positive meningitis sign. There are a few things that can also create this problem, but 95% of the time it's meningitis. Another thing that meningitis does is it causes these petechia that are non-blanching. So if you press on it, it doesn't fade. That's what I mean by non-blanching. So if you happen to have a whiskey glass on your ambulance and you want to check if their rash is a meningitis rash or not, now you know how to. Hydrocephalus. Hydrocephalus is very commonly dealt with younger and younger now because of improvements in ultrasound and improvements in neonatal care, not only pre-birth but post-birth, right? So hydrocephalus is, if you break down the root of the word, hydro is water, cephalus is head. It is an excessive culmination of cerebral spinal fluid around the brain. Basically, it just babies are able to tolerate this a little bit better than adults because they have those open fontanelles. Okay, they get this kind of wild-looking alien vibe. Most of the time, this is very easily fixed through a shunt that is placed into the main ventricle of the brain. It's run down the neck and basically drains out into the abdomen. Okay, if left untreated, Cushing triad is very common because the brain will start to herniate, as with any other intracranial pressure. Here's that shunt we talked about. So basically, there's two different types. It can be up high or it can be down low. So they put a catheter into the ventricles, which the cerebral spinal fluid is produced in the ventricles in the center of the brain. They bring it up and out under the skin, and it goes down into the abdominal area. So this little piece on top, or like if you look in the picture on the right behind the ear, that is the valve. So they can adjust with a magnet how much cerebral spinal fluid is being drained out. So as they get older, or this level of cerebral spinal fluid changes, they can adjust so that they don't have to go back in for more surgery. most of the time, if you have a patient who has a shunt and they start having altered mental status and fever, you should suspect that there is an obstruction or some sort of infection involving their catheter. Okay, that should be like high on your list of suspicions, just to keep kind of the patient safe. So seizures are like the Control-Alt-Delete of the brain, right? There's an abnormal electrical activity that causes the brain to more or less reset. Babies who have seizures are commonly like, they'll have like absence seizures, so like they might just like stare off into the distance for a period of time. It sometimes takes a little while for it to be noticeable, especially if it's not full grand mal seizures. Okay. People or kids who have seizures that are diagnosed, a lot of times non-compliance with their medication can cause breakthrough seizures. Metabolic disturbances, right? So if they've exercised more than anticipated, et cetera, that can cause different levels of seizures. And sometimes you have kids who have progressions of seizures, right? So maybe they started off with absence seizures, and then it went on to a petit mal where maybe only one arm is affected, and then it moves on to a grand mal seizure. That is not uncommon, okay? That pretty much just means that their medications need to be addressed, and they're probably going to need to go follow up with a neurologist, okay? But any new onset of fever in a seizure in a child needs to be evaluated, okay? Commonly, it's fever related if it's under the age of 5. If they're older than that, again, needs to be evaluated. I know it says here that febrile seizures are less than 1 year. That's a major risk factor. But it's, again, it can go up to about the age of 5. I've seen febrile seizures into kids at around the age of 8 as well. But once they start to get older, they start to suspect that it's not febrile, that it is actually neurological. Febrile seizures are, again, relatively self-limiting. They generally don't last very long, okay? Like, if they do last 5 minutes, that's a long febrile seizure. Usually it's like 30 seconds. Their postictal phase is also extremely short, which is good because they recover quickly. Stat ep in a child, 4 to 5 minutes or more, or a recurrent seizure with no intermittent period of consciousness. This is a kid you're going to potentially want to use benzos with, okay? This is your benzodiazepine of choice is going to be your midazolam. It's 0.2 milligrams per kilogram, okay? Which means that you need to go and you need to look at your midazolam packaging and figure out how many milliliters you're drawing up, okay? Because trust me, that's one of those things that you should know. Or have written down somewhere, because you're going to walk in and all of a sudden you have a kid who's seizing in front of you and you're like, oh no, math, okay? So make sure that you understand what, like, if you have a kid who's like this many kilograms, they're going to get this many milliliters. Have like benchmarks for yourself. Endocrine. Most of the time we'll see patients who are type 1 diabetics, okay? You might be seeing kids who are pre-diagnosis, right? Who might have a very high, might be altered mental status and have a very high blood sugar. Or you might have a child who is hypoglycemic status post-diagnosis, which means that either they've, very common like to adults, right? They took too much insulin, they missed a meal, or they were, I don't know, being a kid and playing. Sometimes it's hard in the first few months to a year of a child's life to kind of learn, especially as a parent, how to balance their sugar well. And it changes also as they get older. So it's not uncommon for a diabetic child to have, difficulties in maintaining their blood sugar. As I just said, hyperglycemia in a young child with altered mental status can be the initial symptom of a new diabetes diagnosis, right? All of a sudden, mom notices that the kid is drinking more, eating more, going to the bathroom more, but not gaining any weight. most of the time, if you have a kid who is a diabetic, they are usually type 1. There is this really fun trend in the United States that children are becoming type 2 diabetics earlier and earlier because of morbid obesity. So don't necessarily rule it out. Most of the time, right, we don't have kids aren't really dealing with blood disorders. Like, it's on the more rare side. Sickle cell is probably the more common, and there will be most likely a family history of sickle cell. Nosebleeds, right? Hemophilia is also a potential blood disorder that you're going to see. And again, a lot of times this kid's going to have a known history. GI disorders where there's issues during fetal development. Illness and infection is really going to be your biggest one, right? Where they have food poisoning or diarrhea or some sort of just gastro infection, GI infection. In younger children, a lot of the times these issues are kind of addressed or picked up and addressed prior to their discharge from the hospital. So you will probably be getting a history of it from mom and dad. So vomiting is like, if you actually ever go down the rabbit hole of what causes vomiting and why certain things work and certain things don't, and like people who are empathetic vomiters, enjoy that. That's a fun trip. But for the most part, there's a part of your brain called the emetic center, and when it is stimulated by serotonin, it causes you to vomit. When it's like a young child, overfeeding is usually an issue. Sometimes kids, again, we know kids spit up versus vomit. If they start to get a little distance on their vomit, you want to have a little more of a higher level of suspicion. Toxic ingestion is always an issue. Older children, right, you might be concerned regarding pregnancy, bulimia. Migraines can cause significant vomiting issues. Appendicitis, right? That's always a good question to ask. Hey, do you still have an appendix? Do you have a fever? These are things that you should include in your assessment. So a number of things can cause bleeding. Again, adults and children can have the same issues. Again, we are not going to diagnose these things. We are going to stabilize the patient and go to the hospital. One of the most dangerous things that kids can swallow is a watch battery. Okay? Most of the time it gets stuck in their esophagus, and the lithium ions and the battery acid will burn a hole through their esophagus and then commonly right through to their trachea. Okay? Troublesome. Unintentional ingestions is a hugely preventable cause of death in children. Okay? And again, we talked about your scene size up. Do we have a house where there are significant chemicals just sort of lying about and unsecured? Kids can get into mom or dad's medications very easily, especially, those child-safe tops are not as child-safe as you'd think. You also have teenagers who might be trying to use the drugs recreationally, or because we talked about behavioral disorders and how they pop up in the teenage years, they might be trying to harm themselves. Things that you should consider. So, pediatric trauma, right? Super common. Number one cause of death in children because, again, risk takers. Don't have a lot of really good musculature to protect themselves. Fall down, go boom. Super common. MVAs, also super common. The leading cause of death in young children, most of the time because they were not appropriately secured, right? 1 to 4 years old, they're not properly secured in an appropriately sized child seat, right? There's all sorts of laws now where they're like, oh, well, you have to make sure that the kid's in a booster seat. And I can't tell you the number of times parents don't do that, right? The kid's in a seat or a regular old seat with a seatbelt, and the seatbelt's coming up across their neck instead of across their chest. you're going to have all sorts of problems, okay? And then on the other side, the 15 plus side is, I just got my license, I'm going to drive really fast, right? Troublesome, inexperienced drivers. Pet structs, right? Kids have a completely different injury pattern than adults do, which I do believe we're going to be talking about very shortly. And if anyone's been listening to the radio lately, the Bodie Miller, my 19-month-old baby drowned in a pool at a friend's house, depressing commercial. Kids can float, all right? They're usually, younger kids are pretty good at floating, but it only lasts so long. This is usually a supervision problem. Frank, mute yourself. Frank, mute yourself, please. It's okay. No, they changed it. They changed it. You can be a CFR at 16 and an EMT at 17 now. Because you're emotionally prepared to do that. All right. Anyway, so just because a child has been submerged in water does not necessarily mean that they are drowning. Near drownings are a very common thing as well. And there's also delayed drownings where the fluid comes back up into their lungs and they will drown while sitting on dry land after having been submerged. Penetrating injuries. I mean, we all live in New York. We see the news. Stabbings, shootings, they're very common, unfortunately, right now. Burns, we talked about that already. And child abuse, okay? There's a lot of injuries that children can sustain due to various aspects of child abuse. We talked about the giant pumpkin head. So if a child is improperly secured in their car seat during an MVA, that big old pumpkin head's going to cause their head to come forward, and it's going to put a lot of strain on their cervical spine. That also means that we talked about how there's a little extra space and extra cerebrospinal fluid in their head. We have that extra potentially soft bone, potentially non-closed fontanelles, right? So they can have diffuse brain injuries as their brain bounces around inside their skull. Another rabbit hole, if you really want to fall down, is internal decapitation. Okay, that's usually caused by the acceleration-deceleration motion, and it separates and stretches the spinal cord usually in the cervical spine, and can cause paralysis. That happens in car accidents, and it also happens with like cheerleaders, okay? Like the ones who throw themselves up in the air, the flyers. If they come down and land wrong, they can be internally decapitated. So they look perfectly fine, but they've had some sort of very high spinal cord injury. I highly recommend that rabbit hole. Kids, especially kids in sports, right? Traumatic brain injuries. They have no fear, right? Also kids who have fallen down and go boom, those 3-month-olds who suddenly learned how to roll off of a bed, right? They may have hit their head. Signs of increased intracranial pressure are exactly the same as you would see in adults. The problem is, depending on the age of the child, you might have a delay before you notice the signs and symptoms, right? Especially infants would have open fontanelles. Again, signs of herniation, asymmetrical pupils, abnormal posturing, bradycardia with hypertension, irregular respirations. Cushing's triad, right? Not new. We are familiar with these things. Chest injuries. A lot of the time, because kids do have very flexible ribs, you might not actually be able to see like a broken rib or something, okay? Tension pneumos are very dangerous. Again, remember, teeny tiny, very easily popped lungs. Flail segments are rare, and if you do see a flail segment, it's probably child abuse. And cardiac tamponade, right? Cardiac tamponade, where you have that baby hearts, right? They can compensate. They can go higher and higher and higher in terms of maintaining a pulse, but the blood pressure is going to start to fall. Kids fall off of things all the time. Extremity injuries are very common, okay? But most of the time you won't necessarily see the fracture because they have very soft, pliable bones. Okay, the only thing that you might notice and is tenderness, right? Tenderness and some swelling. That might be the only sign. So if you have a kid with an extremity injury, highly recommended that you splint and do all the same appropriate treatments that you would do for an adult. Femur fractures are commonly related to child abuse. Okay, again, sometimes you have kids who have pathological issues with their bones, like if you have a child who has osteogenesis imperfecta, but you should have a high index of suspicion for a femur fracture. Burns. Sometimes we have to hurt ourselves to learn. Right, so how many times you have kids who pull hot boiling water or tea or coffee on themselves, or swallow chemical, Drano or something to that effect, or stick a fork in an electrical socket, right? A lot of different things because kids are too curious. If you do have a burn to the airway, you need to be very aggressive, okay? Because small airway, even mild inflammation and swelling can create a significant issue with the airway. Even with the same with adults, when you say electrical burns, you should have a high index of suspicion for musculoskeletal injuries. It's the same for adults and children. The only thing is you might not notice in a child if there is a vertebral abnormality, because again, flexible bones. So we talked about trauma management in the child and the airway in general. Make sure the patient is in a sniffing position. This might mean that you need to pad underneath their shoulders. Be gentle if you are ventilating. Tiny lungs, easy to pop. This is a great thing. This is called the papoose. I've only ever seen this on a Brentwood Legion ambulance. But what's the problem? If you look at this kid right here, what's the problem with her? I think it's her. She's wearing a flowery shirt. What's the problem with her positioning? Exactly. The padding looks like it's under her head. So her airway is down. There's not going to be an adequate airway maintenance there. The papoose is really great because it actually has these elastic bands that hold every single limb down individually, because kids move, right? Kids are very can get very frantic during a traumatic incident. Okay, so this helps kind of keep them secure, and it's not a bad thing to put a cervical collar on a kid if you have a high index of suspicion. Depending on your age, the age of the child is going to be depending on whether or not you're doing an IV or an IO. Pain relief should be a priority, but again, this is something where you're going to be involving mom and dad with. Okay, I had a kid once who she dislocated her knee, and I was like, "Do you want me to give her pain meds?" Like, because her dad was at the house, and dad was a volunteer because I was working for one of the volleys, and I was like, "Do you want me to give her some morphine?" He's like, "Nah, she's good." And I was like, "All right, suck it up, kid." Like, she was on her own. But sometimes you have to advocate, right? So maybe if there's like a very, extreme injury, you might want to be like, yeah, no, they need that. This is the pediatric trauma score. If the child, you give points for each area, obviously, and depending on how many points the child has is depending on how well their prognosis is. So just something to enhance your education. So SIDS. SIDS is one of those things, and they call it sudden unexpected infant death now. Is extremely traumatic for the parents, okay? There's no rhyme or reason as to what causes it. They aren't sure if it's a congenital issue, if it's a, what's going on. But most of the time they'll put baby down for the night, and then in the morning they come in and baby's dead, commonly in rigor mortis. Okay. Most of the time, even upon investigation, they do not find anything significant. Okay. And this is one of those things where you might need to transport the baby for mom and dad's mental health. Okay. Mental well-being. This is also one of those really tough calls for you as a provider, because you are kind of in a helpless situation. Okay. If it's not your fault, there's nothing you can do. But it's one of those things where maybe you need to talk to somebody. That's perfectly acceptable. Child abuse and neglect is another situation where you may feel a little bit on the helpless side, and or that it's kind of a lot in terms of emotionally. There's a variety of ways that people abuse their children, unfortunately, from physical injury to sexual abuse, emotional and psychological abuse, which is frequently not even noticeable because it's so insidious and it's just the way that perhaps the parent interacts with the child. Kids who have special needs and or like intellectual issues are at high risk of being high risk for abuse. Adults who have been abused are more likely to be abusers themselves, unfortunately. It's usually an ongoing pattern of unstable behavior. It's not like a singular act of violence. It's not just because, mom or dad lost patience with the kid and smacked them. It's a culture, an entire environment and culture of abuse, where maybe they're not feeding the child enough, maybe they're hitting them, maybe they're putting them in situations that make the child scared or uncomfortable. Okay, we are mandatory reporters. Okay, so make sure to, again, head on a swivel, kind of keep your eyes open for any potential issues that you need to be aware of. Commonly, if you have a story that doesn't make sense, that should be your first indicator, right? Like the 3-month-old who rolled off of the bed. Okay. Kid who, broke a bone, but the story of how they broke the bone doesn't make sense. Okay. Skin infections, long-standing skin infections. Okay. Clothing that doesn't fit. It's a number of different things, and a lot of these, are kind of, what's the word? Common sense, I guess, where you're like, as a provider, you're like, well, that doesn't make sense. Like, what? Like, no. Like, I don't think so, right? Listen to your gut when it comes to those situations, and make sure that, you talk to, if you can, and if the age appropriate, talk to the child separately. Various physical findings that you might see, blood force to the abdomen due to, and with, concurrent vomiting, etc. Any sort of bruising that looks like a hand or a belt, right? Welts, etc. Could be concerned. Delays in seeking medical care. While there's also delays in seeking medical care for a child, there's also the Munchausen's by proxy, right, where the mom and or dad gets the kid sick and is constantly bringing them to the hospital. That's also a form of child abuse. Okay. Bone injuries that are not like they don't have a good story. Sexual abuse, right? Young children who end up pregnant or having an STD. I feel like a lot of these aren't necessarily things that you're going to be called for from the home. You might be called into a school after the school nurse or something notices some of these issues. Mostly because we don't do a lot of we don't really assess the genitalia. Young children who are a little too comfortable with sex, that's a huge sign of a potential sexual abuse, right? They know words, they know things that they shouldn't know as a young child. That should be a high level of concern. When you have children who have special needs, you really should kind of defer to the parents or the caregivers, because most of the time, those people are going to be your experts. They, in order to take that child home, they have received special training in order to care for their child. Or they have like a special caregiver who is there depending on how good their insurance is. Tracheostomy tubes, when a small child, they do not, if anyone's ever worked in the private aspect or has seen an adult tracheostomy tube, it's two parts. There is the outer lumen and the inner lumen. Kids with tracheostomy tubes frequently only have the flexible single lumen, okay? I've definitely transported a small child who coughed his tracheostomy tube out. Like he went, and it went bloop, and I was like, ah. And mom was like, oh, no problem, and stuffed it back in, okay? So kids who have these special needs, their parents are usually kind of like, no biggie, right? If mom and dad are freaking out, that's probably a good time for you to quietly freak out in your head, okay? Because that means that there's something way out of the norm. Primarily, the younger the child, the less likely it is to be a cuffed tracheostomy tube. If you are transporting a child with a tracheostomy tube for a tracheostomy issue, most of the time the family or the facility, wherever they are, will have an additional tube with them. Try to grab it, okay? Because then you have the brand name, the size, if it's cuffed or uncuffed, because sometimes if you are unable to take them to the hospital where they would like to go, that other hospital might not stock the same brand, okay? So if you have it with them and it's for a tracheostomy tube replacement, if you bring one with you, the hospital can do what they need to do, make sure it's in the right place, and not change the hardware, so to speak. Home ventilators. In the New York City system, you are not allowed to transport a patient on a ventilator. Okay? However, if mom or the home health aide or the nurse is willing to take responsibility for the ventilator, you can keep the child or even the adult on the ventilator for the transport. Okay? Unless, of course, there's something wrong with the ventilator, or the patient has an airway obstruction or mucus plug, or is in significant respiratory distress where you need to ventilate with a BVM, okay? It's very uncomfortable for vented patients to switch from one machine to the other. It's uncomfortable for those patients to be BVM'd. A ventilator most of the time will humidify that oxygen for them, so it's a lot more comfortable. A lot of times the settings that they have are very comfortable for them. And as they get older, obviously as a child, etc., gets older and larger, they will adjust those settings, but to move them from one machine to the next machine can be a little on the distressing side, okay? Central lines, again, we don't touch these. If it's bleeding or something to that effect, you're going to fix that. You're going to try to, stop the bleeding. You have to clamp it, perhaps with an umbilical clamp. Sometimes you have to be a little creative. Most of the time, the issues that you're going to notice is maybe a little bit of infection around the site, where you have like arrhythmia or some pus or something else. These kids are, if a kid has a central line, like they're probably really ill, okay? G tubes and gastronomy tubes, depending on where it's placed, depends on what it's called. The very little children, they'll just put an OG or NG tube in, right? So they'll cause here, but after a while, it causes so much irritation to all the mucosa that they put it in through the abdominal wall. When they're really little, they have just like a little stem. It's not like a full tube like you'd see in adults. These kids, again, might have some issues when it comes to feeding and through the mouth, so they have this. Not really anything that you're going to do one way or the other in regards to this. If it comes out, you take it with you. Make sure that the site of the ostomy is clean and bandaged, not really a quote-unquote emergency. All right, cool. Questions, thoughts, concerns? So it's either they are BVM'd or a family member or someone else who is responsible for their care takes responsibility, and then they are the ones who are responsible for the vent. So you can move the patient over on the vent, you keep them on the ventilator, but you do not touch the settings, you do not touch, that becomes the sole responsibility of whoever the caretaker is. Yeah. Yeah. Yeah, so usually, or the respiratory therapist. Usually, you can keep them on the same settings. So, like if you're doing private transport and you're vent authorized, yes, you'll have the list of settings that you're going to be transferring them on. Yeah, well, then that's your authorized. In the New York City 911 system, there's the is not authorized. Not authorized. Brianna, you were saying something? That so Northwell works outside of that the 911 system. So that's still that critical care transport is considered a private transport. It's not a 911. Yeah, that's how they get around that. Anybody else? No. Yeah, because it's a surgically implanted airway. So as BLS, as transport BLS, yes, you are authorized, especially if it's a critical patient, you are authorized to ventilate. You know how to do that. If it was something where it's like, oh, the tracheostomy might have been displaced or something like that, it could be tricky. All right, cool. A capnography and deep trach suctioning. Because if, heaven forbid, you're transporting this patient, and most of the time, vent patients do not want to go to the closest hospital. Like, I want to say, like, 89% of the time, they're like, can you take me to that one? And you're like, that's like 3 states away. So you might need deep trach suctioning or some other, like, interventions while you're transporting. So, all right. Come back in 5 minutes, okay? And we'll do geriatrics and we'll be done for the day. Should probably actually share that, huh? Hey, hey. If you weren't depressed enough about all of the OBGYN things, just wait till you find out all the wonderful things that happen when you get old. It is actually the first sign of becoming old. It's unfortunate. Um, so like let's just go let's get it out of the way. Ready? Hashtag boomer. So geriatric patients are considered those who are 65 years or older. So significant number of people in the United States are 65 years and older. Our birth rate is actually dropping, which means that we are not repopulating as fast as we are getting old. It is actually the fastest growing demographic in America, which leads us to this concern that we won't have anywhere to put these people, especially as people start to get older because of improved medical care, right? So people are like, usually it's like, you hit like 70 and you like died of a massive heart attack. Now it's like you get to 70, they're like, we're gonna give you stents, and then you're like, fantastic, and then you're out playing golf till you're 90. But then not everybody is that healthy, right? you still have people who require intensive levels of care, who are in nursing homes, etc. We have a nursing home shortage and an assisted living shortage, so it becomes an issue. Unsurprisingly, more than 40% of all EMS responses for adults are for older adults. Most of the time, it's a chest pain or syncope, strokes, various cardiac calls, cardiac arrest. Okay, not telling you guys anything you don't already know from working the system. We talked about this already. So most of the time, and there's kind of a push in the world as a whole, is that we're taking caregiving out of facilities and back into the home. Culturally, there are some cultures that are way better at that than other cultures. For example, Hispanic cultures, Italian cultures, people, the people who are very family focused, where you have like some of the more independent thought, northern climate kind of Norwegian, Sweden, etc., where they're like, we're not going to have you. Well, maybe put a little grandma home over here in the corner, right? So culturally, it's very different depending on where you're from and what your background is, how we treat our elders. Unfortunately, there's not a really good answer for this, because not only are you now putting yourself potentially at a financial loss for being a caregiver, even though they have put things in place like caregiving, like funds for caregivers, but the problem is now is also a huge burden for the person who is the caregiver, okay? And that opens the elderly up for other versions of abuse, since we kind of built off of that from the pediatric side. Legally and ethically, there's a lot of different issues. For example, we in the EMS field do not recognize living wills or durable power of attorney. We will acknowledge DNRs and MOLSTs. We will allow elderly patients who are at A&O times 3 to make, to be autonomous and make their own decisions. But we can't, even though a living will may be legal, it does not mean anything to us in the pre-hospital field. That does not mean, however, that if you have a patient who is in cardiac arrest, whose family presents you with a living will, that you cannot call medical control and say the patient's family does not have a DNR, patient's in cardiac arrest, the living will is here, I have a durable power of attorney, the family doesn't want anything done over and above, they would like them to die peacefully, can I terminate? Most of the time, medical control will say yes, okay, because those wishes have been put in writing. And as EMS, again, going back to the power that we have as EMS professionals, there are lots of people who do not know that they need to have a DNR MOLST in place, even though they may know that they have terminal cancer, or they are in hospice, or they're 98 years old, right? These things are not necessarily discussed, and if they are, they're discussed poorly. So these are maybe some things that you can talk to a family member about, et cetera, to ensure that people's wishes are followed. There's a significant number of transports that are a repeat transport for the same issue. And I'm sure you have all seen that, that patient, like the person who falls a lot, or the patient who doesn't take their blood pressure medication, psychiatric issues, right? Those frequent flyers, but like the like elderly frequent flyer who maybe doesn't have a support system. And these are the people who you might want to talk to the triage nurse and be like, listen, they need some social nets, like the social worker needs to talk to them. Like they need some level of support at home. And when the Affordable Care Act was put into place, this 30-day response transportation opened up the door that if you were readmitted to the hospital for the same complaint within 30 days, that they would not pay the same, or they would not pay the original or the follow-up visit, because it was trying to hold physicians accountable and hospitals accountable for ensuring that adequate care was provided. And unfortunately, this kind of goes back to EMS has special powers where doctors aren't seeing what's going on in the home. So we need to fill in those gaps for everyone. So gerontology is the study of problems related to aging. Most of the time, changes in functionality occurs due to various stressors, right? So you might be like feeling fantastic and you're in good shape and you play golf 3 times a week, and then you trip and fall on the golf course and you break your foot, right? Oh, well, you recover, but you don't ever get back to that same level of activity you did before, right? And then it sort of becomes a downward spiral from there. And there comes a breaking point in someone's life where the stressor becomes too much and now they become dependent for care. And those of y'all who are around 30 years old, get excited because functionality declines in a predictable fashion every decade after 30 at about 5 to 10%. Say goodbye to that imaginary six-pack we all were talking about earlier. As you get older, the respiratory system starts to decline, right? So the intercostal muscles are weakened, the abdominal wall is weakened, which means you can't necessarily recruit those muscles to bring the diaphragm down. Lungs start to decrease in size. They're not as elastic, so that recoil is not as robust, which means you have more dead space inside the air where the air is just retained. And the alveoli start to kind of become more shallow. And this is also a combination of if you have done anything also to yourself, such as smoking, right? Smoking causes all sorts of issues in terms of alveolar function, and cancers and elasticity, etc. Well established. By the time you hit 75, your vital capacity is decreased by as much as 50%, right? So what you can do now at whatever age you are, by the time you get to 75, half it. Okay? So that means going upstairs is going to be more difficult. That means that coughing, right? We talked about, what's the word? Aspiration. Right? We talked about how aspiration is increased as you get older because you have a diminished cough reflex and an impaired gag reflex, right? So food just going to go right where it wants to go with no consideration of your, opinions of the whole matter. The loss of cilia also, right? So cilia is those little hairs that help move mucus up in throughout the lungs. And if those start to become either paralyzed or missing, all that mucus kind of just sits there, right? How many people have ever had an elderly person who just has that cough and it just rattles, right? And you just hear all the mucus kind of going, and you're like, oh my. That's because there is a lack of the cilia that brings it up. Most of the time you don't even notice that the cilia is doing something because you just swallow the mucus. The heart also starts to become less effective, right? So the muscles start to get weaker. You lose the ability to compensate as effectively as when you were younger. There is an increased rate and risk of ischemic tissue caused by MIs and all sorts of other issues related to atherosclerosis. Your heart doesn't respond as effectively to an epinephrine release, okay? And a significant release of epinephrine from that fight or flight response can cause significant stress on a heart that is not capable of compensating. So that can create all sorts of issues as well. As you get older, the electrical conduction system also starts to kind of break down. So older patients are at increased risk for heart blocks and bradycardias. Also, AFib is increased risk. It's usually right around the area of the aorta. Those cells start to get a little pissy and they start to create the fibrillatory issue. Any sort of unexpected stress in the elderly can cause a cardiac arrest, okay? And this is kind of evident when you see this couple was married for 80 years and she died and then he died the next day, right? that's an unexpected stress that causes the heart to kind of just quit. This could also be due to a lifetime's worth of coronary artery disease, right? Or hemodynamic changes, or increased vagal tone, right? When you're on the bathroom, sometimes that's a stressor enough. Your kidneys, which, bless them, are part of some of the busiest organs in your body, start to have decreased blood flow after your age of 20. Let's talk about how old you feel now. At 20, your renal blood flow starts to decrease by 10% every decade. Okay? Depressing. And then at 30, your renal mass starts to also decrease, okay? Which means they're just getting smaller, which means they don't have as many functional units, which means that you're not as good as filtering your blood, which increases the risk of various toxicity, right? But hey, let's give the 80-year-old a renal toxic medication such as amiodarone. It's fine. They'll walk it off. Overall, as the kidneys do get smaller, they also at increased risk for infection and occlusion, etc. Interesting fact, patients who have uncontrollable hypertension should be receiving a kidney ultrasound to determine if they have adequate blood flow to the kidneys. The kidneys control your blood pressure. That's really important, right? If they don't feel like they're getting enough blood, they're going to release antidiuretic hormone and all sorts of other vasopressors in order to increase your blood pressure. So if you have arterial occlusions, like secondary to like atherosclerosis in your renal arteries, the kidneys will be like, hey, where's my blood? And start to release all of the hormones necessary to increase your blood pressure. But it's because there's a restriction in the artery, not because of anything cardiac related. So renal duplex should be a standard component of patients who have uncontrollable hypertension, but it's not here in America, unfortunately. You have to really talk about it, like convince your doctor to do it. So as you get older and your kidneys start to become a little less effective or efficient, they aren't able to concentrate urine as much, which means that you are going to be producing more watery urine, which means that they have to work harder, which means you have to walk to the bathroom more. More sodium gets released, which is why elderly people are commonly hyponatremic. And there's just, a lot of time back and forth to the bathroom. Elderly people commonly are on many different medications, okay? One of the best things you can do for yourself as a younger human is to take good care of yourself so that when you are an older human, you don't have to take all of these various medications. A lot of times patients might take their medication wrong or not take it at all or become depressed and want to kill themselves, so they'll just take a whole bunch of different drugs. We still give out narcotic pain medication like candy. I have definitely Narcaned a number of grandmas because of fentanyl patches that as you get older, your subcutaneous fat thins out, which means that topical medication is absorbed much more easily, which means that if you give grandma a 100 microgram fentanyl patch, she's going to absorb all 100 mics really fast. It's not the same as when you give it to someone who has an adequate amount of subcutaneous fat. GI disorders. GI bleeds are super common in the elderly. Okay, the first GI bleed is usually the worst. Cardiac events, various metabolic and or renal issues and electrolyte issues. All of these things can be caused by medications or be an underlying cause that are now exacerbated by medications. There are a number of medications that you do need to reduce when you're giving them to an older adult. You can find those in your GOPs. Highly recommend you look at those because those pop up pretty frequently. As you get older, your brain actually does reduce in size, which is part of the reason why, similarly to when you have a pediatric patient who might have a traumatic brain injury, as an older patient, as the brain takes up less space in the skull, there's more room for blood. So Cushing's syndrome or signs of herniation might not show up right away. It might take an extended period of time before it's noticeable. It also, there's an increased risk of intracranial bleeding. Bleh, that was hard to say. Intracranial bleeding, because all of those arteries and veins become much more delicate, right? So you bop somebody's head around, you're going to potentially cause a significant amount of bleeding. In terms of the neurons themselves, you actually do have a decrease in neurons, which is frequently associated with memory loss, forgetfulness, etc. However, if you do keep yourself and your brain active, you can reduce a lot of those issues, okay? And this is part of the reason why people who work in a very cognitive field that has some sort of intellectual demand on them will overall experience minimal changes to their cognition as they get older, right? But people who don't constantly try to stimulate their brain will frequently have much more of a higher incidence of Alzheimer's and dementia. Sleep patterns change significantly as you get older. As an EMS professional, you don't have sleep patterns, so who knows what we're doing. Older people also tend to sleep less, or at different times. Like they might take a nice nap during the day, which totally jealous. Mental functioning can also be significantly impaired by a number of different medications. For example, statin drugs. So your brain is 90-something% cholesterol. Okay. Now we have this cholesterol and hypertension issue in the United States, where we put a significant number of people on statin drugs to bring their cholesterol down. The problem with the statin drugs is they are not especially specific as to where they're taking the cholesterol from. So the decreased cholesterol also impacts the brain. So you have all of the cholesterol as the myelin sheath that's protecting the nerves. The longer you're on statin drugs, the higher possibility exists that that's going to affect the myelin sheath and it's going to create mental fogginess. It's scary. Like it happened to my mom. She was on a statin drug and she is a very sharp woman. And then all of a sudden she was fuzzy, like really fuzzy. Like she would forget things that she would otherwise never have forgotten. She would be very like lost and confused a lot, and it wasn't her. And we talked to the doctor, and the doctor's like, oh, it sounds like you're having a bad reaction to the statin. Let's take you off of it. Took her off. Boom. Mental acuity improved. So just things that you should keep in mind when you are assessing an older patient. One of the best things that you can do for yourself is make sure that you maintain your posture appropriately. And especially now that we all have phones and we all are bending over our phones, kyphosis starts at the neck, okay? And it creates this humpback. And it's bad enough that gravity is a bitch and makes you shrink for about 2 to 3 inches, but now kyphosis can make you even shorter. Kyphotic patients can have a very difficult airway just based on the way that their neck is positioned, okay? It might be very challenging to put this patient in a collar or to tube them or to transport them comfortably, okay? And now also look at the way that the chest is shaped. Now you're going to also decrease the amount of chest excursion available, which means that it's going to be harder for this person to breathe. Your muscles do start to shrink. You do note there's a noticeable decrease in the amount of muscle mass that one has as they get older. This can be easily prevented through strength training and lifting weights. As you get older, your lean body fat starts to turn into your lean body mass, like muscle, starts to turn into fat. which also helps make drug dosaging more challenging. Your total body water, like you start your life as an infant with very high total body water, and as you die, you get a little dusty, unfortunately, and have an overall decrease in total body water. Temperature control is extremely difficult. Because now, instead of having an underdeveloped hypothalamus, your hypothalamus is just tired. Older people, you actually will see that older people do not sweat much, because as you get older, your sweat glands actually shut down. And as you get older as well, you have a number of people who have nutritional issues because they're not absorbing vitamins and nutrients well, or they are unable to eat because of dentures or ill-fitting dentures that cause them pain or difficulty chewing. Okay, so they might just avoid eating overall. Or you have patients as well who have a limited income, right? So they might not be able to afford the food that they really do need. As you're assessing an elderly patient, you need to ensure that you consider the entire picture. Okay, comorbidities are essential. Okay, it's very rare when you find someone who says, who's like in their 80s and says, I don't have any medical problems. Okay, either they haven't gone to the doctor in a long time, or they're really like one of the elite healthy elderly. Acute on chronic illnesses, right? So you have a patient who perhaps they have COPD, but now they have pneumonia on top of it, right? And those become more complex, okay? So now how are you going to treat this? How are you going to manage this patient? Patients also don't experience the same pain response as they did due to decreased neural function and speed of nerve transmissions. And there's a lot of other concerns, right? So I don't know, has anyone ever gone to take an elderly person to the hospital and they're like, no, I don't want to go, because they're afraid that they're never going to get out of the hospital, or they're going to be sent to a nursing home. Or they're not going to be able to afford it because, again, that fixed income becomes a huge issue, as well as the fear of losing their ability to take care of themselves. A lot of the elderly patients that you deal with are probably going to be in relative denial about the fact that they're getting older, because no one really ever wants to accept that. Patient history might be a little more complex. Patients might not really want to talk about it because, how many times have they gone to the hospital recently? And how many times have they had to tell the same story over and over? And, oh, can you just please take me to this hospital because they know me there, right? Sometimes you really should honor that wish if you can, because it does ease their transition into, ease the patient care transition. Make sure that the patient can hear you, right? Hearing aids are essential, glasses, dentures, anything that they might need when they're going to the hospital. Be respectful, right? Don't honey, dear, none of that crap. And be gentle. I can't tell you the number of times I've seen people kind of manhandle the elderly. Like, they deserve better than that. One of the biggest things that you're going to have, I think, a concern with is the layers of clothing that a lot of elderly patients wear. If you do, for some reason, need to get to them because they've been injured, or you need to do an EKG, this might be somewhat time-consuming. Rolled up on a job a bunch of years ago is an elderly man who crossed the street, like he kind of like walked into a car and he got clipped by a mirror, and when he got taken down, he hit the side of his head on the curb, like kind of $1 Million Baby-esque, where like he just hit the side of his head and was knocked unconscious. And we happened to be turning the corner like right as it happened, and he was wearing like 3 sweaters, a fluffy jacket, and a scarf. So just trying to get him undressed was a challenge, right? Because everyone knows you don't cut a fluffy jacket. They try to explain this to the hospital, like, why didn't you cut his jacket? We're like, don't do it. And they did it. We're like, never mind. Yep, it's all you. You can clean up the feathers. Explain, just like when you would do with a child or any other patient, explain to the patient what you're doing. Like, I don't know why this needs to be said, because you should be doing this regardless. One of the bigger issues is kind of determining if it's a chronic concern or it's an acute concern, right? So, okay, this patient usually walks to the corner store and they come back and they're short of breath, but they sit down and it gets better. Okay, well, they walked to the corner store, they came back, they sat down, it's not better. And it hasn't gotten better. Okay, that's a change. That's an acute symptom. Okay, patient's no longer able to walk. Okay, a patient fell yesterday and now they're confused. There's a lot of different scenarios for the elderly that you're going to kind of encounter that are going to potentially require a certain level of investigation on your part. Okay, because now you have to kind of parse out what is chronic and what is acute. And having a good historian on scene is going to be ideal. I don't know anyone who really does this. You can if you want, but it's honestly some of the best ways to get a good idea of a patient's cognitive function is to just talk to them. I don't hold it against a patient if they don't know what day it is. Frankly, I don't know what day it is half the time. Sometimes you have to kind of mold your questions around the patient and what the patient's habits are. Okay, if the patient doesn't leave the house because they don't have great ambulation, they're not necessarily going to know what day it is. They should know what year it is. They should have an idea of like current events. You could talk to them in so much as that, but you'll get a feel. Sometimes asking your traditional questions are not the most helpful when it comes to the elderly. The family is a really good resource, though. You really should determine whether or not the patient is at their baseline, or if they're not. Most of the time, the patients be like, we called because they're more confused than normal. It's not like a surprise one way or the other. So we talked about bacterial pneumonia already, right? Very commonly caused by a level of aspiration, the inability to swallow appropriately, and decreased chest wall muscles that won't help, that aren't able to help get that sputum up and out. COPD often is very easily exacerbated. It can cause patients a lot of difficulty breathing, which can be scary. I don't think anyone would argue with the fact that not being able to breathe is a terrifying idea. In terms of the cardiovascular system, right, we have the myocardial infarction, which may or may not present with serious symptoms, right? They might be more vague due to comorbidities or a decrease in pain reception. And heart failure. Heart failure is super common. It's one of the most researched topics in regards to chronic illnesses, because there's just this push for trying to keep heart failure patients out of the hospital, because the more frequently they go into the hospital, the more likely they are to die. Okay, their morbidity and mortality starts to increase. These patients are on a boatload of medication. Okay, and most of the time around the holidays, when you start seeing like rich, salty foods being eaten, is when you start seeing heart failure patients pop up. Diagnosed and undiagnosed heart failure patients. Hypertension, super common. Patients will very often have a variety of different dysrhythmias, most commonly AFib, a lot of the times caused by electrolyte imbalances. Remember, elderly patients tend to be hyponatremic, so cardiac dysrhythmias associated with low sodium are very common. As one gets older, increased risk for abdominal and thoracic aneurysms. Again, you may or may not be diagnosing it. You might have a patient who's in cardiac arrest status post a ruptured aneurysm. You might notice or feel the aneurysm itself if you're doing an abdominal assessment. You might have different blood pressures. Again, not really a huge variance from when you have an older or an adult patient, but something to keep in mind as a increased risk. We talked about hypertension. Hypertension, the considered a hypertensive crisis is over 180, over 120, but again, it also can be anywhere where somebody has experienced end organ issues, right? So severe headaches, nosebleeds, dizziness, vomiting, etc. Chronic uncontrolled hypertension can provide you with a slew of other medical problems, all of which we have discussed in the past. We won't beat a dead horse. Cerebral vascular disease has a number of different issues, including not only Alzheimer's and vascular dementia, but stroke. Okay, 40% of stroke patients will have another stroke within 10 years. High risk. Okay, patients who have a TIA are at an increased risk of having a stroke within 30 days. So, history is essential. Also, understanding what the patient's new baseline is after having a stroke is essential, right? So all of a sudden this patient's saying, oh, I can't move my right arm. I'm like, okay, so, when did that start? Oh, after my last stroke. Oh, okay, so is this your baseline now? Yes. As opposed to I had a stroke 10 years ago and I had no deficits, and now I'm having, a facial droop. That's significant. Delirium. Delirium is always a blast and a half. The difference between delirium and dementia is that delirium is reversible. Patients who have dementia, though, are at an increased risk of developing delirium. Delirium is abrupt, acute onset of confusion and altered mentation that could be caused by any number of different things, including electrolyte imbalances, infection, etc. Alcohol abuse is a very common cause of delirium, but if you have an elderly patient who's made it to their elderly years and if they've been a consistent alcohol abuser, that's significant. Here, I don't know why we needed this really fun other acronym. I watched death for causes of delirium. Yeah, no, I don't have a good. It's very similar to your H's and T's, honestly. Your H's and T's will really probably give you the best guidance in determining why a patient is experiencing anything. Okay, let's keep those in mind. Heavy metals, though, let's throw those in there in case they started eating lead paint chips. As much as the normal media, or I guess current media, wants everyone to believe, dementia is not a normal consequence of aging. Dementia is a combination of different things that cause a loss of intellectual functioning, to either mild or severe. If you continually try to keep your brain active, you are less likely to develop dementia. It is nearly impossible for a doctor to differentiate between dementia and Alzheimer's disease when first diagnosing, because most of the time the Alzheimer's disease cannot be diagnosed except through an autopsy, because they're looking for this microscopic buildup of beta amyloid plaques and other quote-unquote tangles in the brain that create a lot of the issues. The problem is that the brain and everything starts to shrink, okay? And as the brain starts to shrink, that increases the risk of intracranial hemorrhaging, okay, right? But with a delayed onset where you don't see it right away. Vascular dementia is usually caused by blockages. So if the same way that if you have a number of small heart attacks, you will have heart failure. If you have a number of small issues or small blockages in the brain, it's considered vascular dementia. It can cause reduced blood flow and therefore reduced cognition. In case having Parkinson's wasn't fun enough, usually within about 10 years of developing Parkinson's, you will also begin to experience cognitive losses. Again, this is also dependent upon the medications that one's taking, but it's very, very common. And as people with Parkinson's are treated for the dementia and then treated for the Parkinson's, a lot of the medications that they take, such as carbidopa, levodopa, cause hallucinations and delirium. So it becomes kind of this convoluted disease trajectory. Lewy body disease dementia, frontotemporal lobe dementia, other varying issues that cause various neurological concerns in the elderly. We're not diagnosing it. We're not treating anything specific about it. So just know the terms. Diabetes. Increased risk of type 2 diabetes as one gets older. A number of, obviously, issues that we associate with diabetes, such as loss of sight, loss of kidneys function, UTIs. There's a whole number of different things, right? But geriatric patients won't necessarily show the classic signs of hyper or hypoglycemia, right? And this is why it's essential when you have an elderly patient who has altered mental status or is unconscious, that you do a full and thorough workup, okay? Hypothyroidism, they're thinking that this might be related to the aging process. Hypo or levothyroid, Synthroid is one of the most commonly prescribed medications in the world, mostly due to this, right? We have this huge, massive, growing elderly population with kind of a low thyroid. So we try to fix that so they can function metabolically appropriately. Confusion, headache, cold intolerance, a lot of the same things that you would see in any other person. We talked about this, myxedema, coma, if the patient has uncontrolled hypothyroid or undiagnosed hypothyroid, significant altered mental status, significant cutaneous symptoms. So, as I said, GI bleeding, the first one's usually the worst, and usually the most fatal. There is a 20% mortality rate of patients over the age of 85 who have a GI hemorrhage. And I'm not talking like a little tiny occult GI bleed where there may be a little on the anemic side here and there. I mean like full-blown vomiting blood, vomiting coffee grounds, or, dark sticky stools. Can be caused by a number of different reasons. Sometimes it's identified, sometimes it's not. Bowel obstructions are super common, okay? As you get older, your gastric motility starts to decrease, and that means that the peristalsis within your intestines slows down, which means that there's an increased risk of blockages. If anyone has ever had any sort of abdominal surgery or colon cancer or a previous hernia, they're also at increased risk. If the patient states that they are no longer able to pass gas or they have begun vomiting fecal matter, which is always a delight, they are a surgical emergency. They are probably impacted and need way more than we can do for them. Incontinence is a kind of, again, complicated issue where you may have patients who have a Foley, or you have patients who are bedbound or have a cognitive or physical disability, or some who have lost like the will to live, right? So if you have none of those things, you have an increased risk of incontinence. The problem with incontinence is that moisture breaks skin down in that general vicinity, and it also increases the risk of a UTI. And UTIs can be very rapidly turned into urosepsis for a patient. Other issues in terms of elimination, we talked about prostate in adult, right? It's one of those potentially benign issues as the prostate gets larger as men get older. Complications due to medications, right? So maybe you have a patient who's on Lasix, who's just like, I have to go to the bathroom all the time. Cancers, various cancers are an issue. Renal failure, right? We talked about dialysis patients. If you need to make sure that they're A, going to dialysis, and B, how much they've been taking, the fluid they've been taking off, and C, that they're not, eating too much salt. Skin becomes thinner, becomes drier, slower for elderly patients to heal, increased risk of infection, increased risk of skin tears. Be cautious when you are putting like the tegaderms and tape on patients, because as the older they get, the more likely they're going to have a skin tear just secondary from like the adhesive, okay? And pressure ulcers. Anyone who's ever worked in privates, you have definitely seen a pressure ulcer. They are staged. I think we have a picture. There we go. They're staged very depending on how significant and how deep they are. Most of the time in bedbound patients, you'll see them on the heels and the sacral area. But they can occur anywhere that there is some level of pressure against the skin that restricts blood flow. Okay, so once the blood flow starts to be restricted, that's when the skin and the tissues start to die. In addition, this is also part of the reason that we stopped using, I mean, it's a small part, but it's part of the reason we stopped using long backboards, because patients were being kept on these long backboards for an extended period of time and developing pressure ulcers. And it also, there was no evidence that actually supported the use of long boards. Osteoarthritis, pain, stiffness in the joints as the joints start to break down, all of that magical cartilage and fluid that's in that joint capsule starts to kind of dry up, because remember, we get dusty. Osteoporosis is a decrease in bone density. Most of the time women experience osteoporosis more than men, and it's due to the loss of estrogen in their system. Weight-bearing exercises decrease your risk of developing osteoporosis. Most of the time, hip fractures, vertebral fractures, wrist fractures are very common secondary to osteoporosis. As you get to around 40, your vision starts to change. So just because, like, for example, I wear glasses for distance, and my dad experiences this right now, is as he got older, he can see far away, but he can't see close. So it can change as you get older. Light sensitivity is an issue, depth perception, and on top of that, your response time. So this is like one of those debates and talking about taking driver's licenses away from elderly people, because they do have a difficult time responding with their reflexes appropriately. Cataracts, most of the time this is treated through surgery, but it is a transparency loss of the lens of the eye, so it's kind of like looking through fuzz. Usually it's in both eyes, usually over the age of 75. Glaucoma, one of the main causes of blindness. It's an increased intraocular pressure that causes damage to the optic nerve, kind of like an aching pain in and around the eye. There's two types. There's narrow angle and wide angle glaucoma. Glaucoma in general does present some concerns regarding some medications that is a contraindication for, but in the grand scheme of emergency medicine in the field, you're not necessarily going to not give a life-saving medication just because the patient has glaucoma. As you get older, your hearing also decreases. Could be due to drugs, could be due to Meniere's disease, could just be due to the changes and the calcifications of the small bones of the ear. If you push Lasix too fast, you can create tinnitus for somebody and they'll probably hate you forever. Speech, again, there's a number of things that can affect speech. So when you're talking to your elderly patient, you need to kind of keep that in mind, that maybe they're having a hard time finding a word, or maybe they are self-conscious about speaking because of dentures, or are having a difficult time forming the shapes that are required to make the word. As you get older, we talked about this already a little bit, that age-related changes will affect the way that drugs are absorbed. And this you'll see a lot when patients are on high blood pressure medication, etc., is that they start to have to tweak what their medications are because it doesn't have the same impact. So they might have a decreased absorption. They might have an increase or decrease of the drug distribution due to body fat issues, depending on what kind of medication. They might have decreased blood flow to the liver, which means that that first pass metabolism isn't going to occur as effectively. And they might have decreased renal function, which means they're not going to excrete the medication effectively. These are some of the more commonly the drugs that more commonly cause toxicity, and I know it kind of looks like all of them. So if you do happen to see a patient who you find that you need to assess for altered mental status or something to that effect, these are some of the medications that you would maybe check to see if they are on. Substance abuse in the geriatric patient is not uncommon. Most of the time it's due to a significant stressor. Loneliness and loss of independence are probably two of the most significant ones that experience, especially in the much older age group, right? You see as people start to see all their loved ones and their friends start to die, they become very depressed. And, they'll self-medicate. We talked about why the elderly are at increased risk of hypothermia already at the beginning, but hypothermia can set in even while indoors. Patients who are septic can also, if they're older, be cold septic rather than have a fever. So things you should take into consideration. Other concerns or other issues that might cause hypothermia include, hypoglycemia, infection we talked about, malnutrition, thyroid, right? Thyroid's really important when it comes to maintaining your metabolism and your body temperature. Hyperthermia is a lot less common, but if it does happen, it does cause significant mortality rate. Again, we talked about how the elderly can't necessarily feel the heat, therefore they can't, and that their mobility is also decreased, so they might not be able to remove themselves from heat, and they don't sweat as much, so they can't cool themselves off. Unsurprisingly, patients, as they get older, start to experience depression because, they're lonely, they may have dementia, they may have other issues. Accidental medication overdoses you might want to consider that it is a suicide attempt, right? So maybe you need to have a difficult discussion with grandma. A lot of the times, patients who are elderly who plan on committing suicide are very successful. To think about it, they don't necessarily need to have a weapon in order to get rid of, to commit suicide. They can go to their primary care doctor and get pain medications and overdose, or overdose on the beta blockers or any other easily accessible medications that can cause death. Clues to suicidal ideations are exactly the same as those that you would see in other patients of different age groups, talking about death, giving away possessions, etc. Trauma in the elderly patient is much more significant than those in the older group. Falls, especially falls that include hip fractures, have a very high morbidity mortality rate. Patients who are hypothermic because they fell and broke a hip and then have spent some time on the floor, very high morbidity mortality rate, okay? Younger patients can compensate much better in traumatic incidences as opposed to patients who are older, because not only are patients older have less compensatory mechanisms, but they're also potentially on medications that are going to prevent those mechanisms. It's like a beta blocker is not going to let their heart rate go up. Blood thinners, they're going to bleed more than you would anticipate, okay? It's not wrong to up triage an elderly trauma patient. Hip fracture is the most common injury status post a fall, and then there's about 20 to 30% mortality rate status post a hip fracture. Depending on where you are and how that treatment is, it could be higher. Again, as a pre-hospital care person, you have power when you walk into someone's home. You are able to identify risks, fall risks, right? So maybe a loose rug or maybe a piece of furniture that's in the way of a hallway. There's a number of things that you can potentially point out to a patient or their family to help reduce their morbidity and mortality risk, because it's not just the fact that they've gotten hurt. Now that they've fallen and hurt themselves, they become less confident. And as their confidence starts to decrease, their ability to move around decreases. And that means that they will become increasingly depressed, and they will have other issues that are related to their lack of mobility. Trauma, vehicular trauma, is significant in the older age group. Again, same reasons as before. Pit strokes, right? Because maybe you didn't cross the street fast enough. People are kind of assholes. Burns, again, just like with babies, there's a significant increase of the risk of morbidity and mortality because of body fluid availability, impaired nutrition. You have less subcutaneous fat, so that first degree burn can potentially be a second degree burn because there's less protective tissue in between. We talked about this already, that as you get older, your brain starts to decrease in size and everything's more fragile in there, and there's an increased amount of bleeding before intracranial pressure is noted. That's it. Grandma over here will almost always look like she had a couple rounds with the Vander Holyfield. Rib fractures. Rib fractures are very dangerous in the elderly. Because not only have the potential to puncture a lung, but it could cause myocardial damage, depending on where the injury is, and it also reduces the vital capacity of the lungs because now the pain, right? They don't want to take a deep breath, so it becomes very, very challenging for elderly people to do well with a chest wall injury. Abdominal injuries. Again, infection is a high risk. Musculoskeletal, mild trauma can fracture a bone. So if you have tenderness, just like with kids, right? If you have some level of tenderness, it's not the wrong thing to ensure that you stabilize and splint. Patients may or not experience the same level of pain. We talked about that already as well. This goes into that permissive hypotension thing a little bit. If you do have a patient who has is a trauma patient and you want to do a fluid bolus, you need to be very cautious in the elderly patient because you can very easily cause volume overload and put that fluid right to their lungs. Heart rate might not be as high as you would expect. So as I said, don't be afraid to up triage somebody. You might have a difficult time ventilating elderly patients, just secondary to chest wall non-compliance, COPD, other underlying issues. Kidneys, not great. Just, again, another potential risk for fluid overload if you do try to improve the patient's blood pressure using fluid volume replacement. Physical deformities, right? We talked about kyphosis, so you might need to be much more cautious about how you position your patient. Make sure you keep them warm. Remember, a cold patient cannot clot, so you want to make sure that you properly package this patient. Much like child abuse, elder abuse is a significant problem. The problem with elder abuse too, though, is that it could also involve financial or material abuse. Okay, so limiting a patient's availability to move around the house, to leave, to go to doctor's appointments, to receive the care they need, to pay their bills, or they make the patient feel like they are dependent upon them for those things. It's all a concern regarding elder abuse. Trying to get in touch with adult protective services can be challenging. So sometimes this is where you might need to separate the patient from an abusive environment and talk to the triage nurse. But yeah, so that's all I've got. Um, that actually can potentially be a legal issue. I mean, obviously, it's all a legal issue, but that you have the possibility of going up to the agency itself and being like, this person is abusing them or whatever. If you can get that information, which might be challenging. Yeah, yeah. Some people are just not suited to be caretakers, unfortunately. Yeah, it does sound normal. Mm-hmm. Yeah, unfortunately, it is a widespread of situations, um, which is kind of unfortunate and tragic. But so, all right, let me pause this.